Good evening,
Good evening.
Shalini.
Good evening, Sapna. I am unable to. I'm stopping it from my mobile. The display actually.
Ma'am, your voice is not clear, it's echoing.
It's going from your end also.
No, ma'am. Actually, you joined in two ID. That's why.
Good evening, Ashutosh sir. Am I audible?
Okay, now it's okay. Yeah,
Yes,
you're
ma'am.
audible. Am I okay?
Yes,
Am
ma'am.
I audible too?
Yes,
Okay.
ma'am. Satya sir, can we start by 7 p.m.?
Hello.
Yes, sir. Can we start by 7?
Yeah, I think Dr. Ashutosh is here only, so I
Yes.
think we can start. I think.
Okay, sir.
Hello, Ashutosh.
Hello, sir.
Good evening.
Good evening, sir. Am I audible?
Yes, sir.
Okay.
Have we contacted the other speakers also?
Yes, sir. Everyone has been reminded.
Yeah. Okay.
Good evening, everyone. A very warm welcome to all our distinguished faculty members, respected doctors, healthcare professionals, researchers, students, industry partners, and participants joining us today. On behalf of International Association for Integrated Oncology, it's my pleasure to welcome you to today's virtual scientific meeting IAIO Expert Insights webinar focusing on gynecological cancer. Our theme for this session is Paradigm Shifts in Cervical Cancer, translating clinical trials to clinical practice. We have an incredible lineup of experts tonight to break down the latest data reshaping our clinical approaches. To officially open the evening and set the contest for the scientific program, it is my absolute pleasure to invite our Program Director Dr. Satya Sadhan Sarangi, Senior Consultant of Medical Oncology at Medanta Super Speciality Hospital, Noida. Over to you, sir.
So, thank you, and I welcome everyone. Good evening, all respected members. To set the context today, I'd like to start by saying this. If we all are following the recent ESMOs and the ESCOs meeting, especially in the gynecological malignancy context, we all would agree that we are on the verge of something new. A new era awaits for the management of the cervical cancer. And this new era is not only for the systemic arena, it is there for the surgical domain also, and is there in the form of advanced radiation technology like the uses of IMRT, the image guidance, adaptive brachytherapy, the de-escalation surgical trials, and obviously the introduction of the immunotherapy into the management of cervical cancer. Plus, not only the immunotherapy, the next in line will is the antibody drug conjugates, which is currently as of now approved in the second line, but slowly and slowly other antibody drug conjugates like Nectin-4 antibody drug conjugate, the uses of immunotherapy before and after the radiation in locally advanced cervical cancer in the form of the Colibri trial or the Atomic C trial, in which they are evaluating the role of maintenance dostarlimab after the completion of CTRT. So everything, all in all, is pointing towards one thing, that something new is going to happen in this era of precision oncology. And to set the and to start the ball rolling today, I would like to invite my dear friend. He is an alumnus from the one of the oldest institutes of Delhi, the Dharmshala Narayana. And I would like to welcome Dr. Ashutosh Jaiswal to talk on the topic of redefining the backbone and the landmark trial called Keynote A18. Dr. Ashutosh, please.
Thank you, Dr. Satya, for inviting me, and I thank IO to give me this opportunity to present the data. I'm going to share my slides. Uh, are my slides visible?
No, sir.
Is it visible now?
No, sir. Yes, sir.
Okay.
So please do the presentation mode.
Just a minute.
Yes, sir.
Okay. So, so today's topic is the role of immunotherapy in locally advanced cervical cancer, and integrating the data of Keynote A18 into our clinical practices. So as you can see, this is the algorithm for treating cervical cancer, which was published in ESMO in 2017. And you can see that locally advanced disease in FIGO 1, 2, 3, FIGO 4A was primarily treated with chemoradiotherapy, along with the need of neoadjuvant chemotherapy as required. And this is the historical baseline, which shows that for past 25 years, the mainstay of treatment of locally advanced cervical cancer has been concurrent chemoradiotherapy. And in 25 years, the 5 year survival rate has been between 47 to 80%, depending on the stage, until 2024, when the keynote A18 data came. So as we can see, the in patients with advanced disease with or nodal involvement, there was huge unmet need beyond standard CTRT, and Keynote A18 provided a little bit of hope in that sense. So Keynote A18 were data that is pembrolizumab or placebo with chemoradiotherapy followed by pembro or placebo for newly diagnosed high-risk locally advanced cancer, started to enroll the patient in 2019, 2020 to 2022. So this is the immunotherapy rationale to use immunotherapy in cervical cancer. So as we can see, radiotherapy and chemotherapy, they cause tumor death, tumor cell death. They release new antigen into the tumor microenvironment. Chemotherapy alters the microenvironment and upregulates the local immune response. And then checkpoint blockade blocks the inhibitory PD-1 PD-L1 pathway and allows T cell to attack the tumor cell. In short, pembrolizumab removes the brakes on the immune cells to act on the tumor cells. This was the study design of Keynote A18 phase 3 trial. It enrolled approximately 1,060 patients across 176 centers over 30 countries. And these patients were then randomized in 1:1 fashion in uh, intervention arm where pembrolizumab 200 milligram was given every 3 weekly along with weekly cisplatin and radiotherapy and which was followed by maintenance phase of 15 infusions, where pembrolizumab 400 milligram was given every 6 weeks. And the control arm had the placebo in place of pembrolizumab and followed same schema. The primary endpoints were PFS and OS. So, how was the high risk population defined in this trial? This trial took PIVO 2014 staging and defined high risk patient for this trial as 1B2 to stage 2B patient who were node positive. This required confirmed pelvic or para-aortic nodal positivity and stage 3, 4A, where extensive local disease was there, include regardless of nodal status. So there was a highly specific inclusion criteria which was targeted towards patients with higher risk of systemic micrometastatic disease. This is the inclusion and exclusion criteria. High risk locally advanced cancer, as I described, were taken who were histologically confirmed squamous cell adenocarcinoma or adenosquamous carcinoma with no prior definitive therapy and were immunotherapy naive. Female patient, non-pregnant, and were using effective contraception with good ECOG performance status of 0 and 1, having radiographically evaluable disease with adequate organ function. And then there were other having other exclusion criteria where these conditions were not met. Fever stage 4B, other histologies were excluded, immunodeficient, having pregnant patients, they were all excluded from this trial. Okay, the slide is a little bit shaky, but this slide shows that the patient in both intervention and control arms were well balanced with median age of approximately 50% in both. 1B2 and 2B stage 1 were both in approximately 44% in both the arms. Stage 3, 4A were approximately 56% in both the arms. And approximately more than 95% were have PDL1 of more than one. Only 4 to 5% were PDL1 negative. So this data was um, evaluated was patients were enrolled until December 22, and the first interim analysis was done in Jan 23, where the 24-month PFS, the primary endpoint of PFS was met with 24-month PFS was 67.8% versus 57.3%, with hazard ratio of 0.7 and p-value of 0.002. In subsequent interim analysis, the endpoint of OS was 36 months. OS was also met with 81.8%, 31 months OS, 36 months OS in pembrolizumab arm versus 74% in placebo arm. Hazard ratio was 70.73 with the significant p-value. As we can see in this graph, there was very early suppression approximately at 3 months for the progression-free survival in interim analysis 1. And there was 30% reduction in risk of progression or death with hazard ratio of 0.7. And For 24-month PFS was 68% in pembrolizumab arm versus 57% in placebo arm. Similarly, in interim analysis two, primary endpoint of overall survival was also met. There was 33% reduction in risk of death, hazard ratio of 0.67 with significant p-value. So this statistically significant OS benefit established this regimen as practice changer in the curative intent setting. However, there were few subgroup analysis which were done. The impact of PDL1 expression, which shows that when CPS was more than one, the hazard ratio, the data favored more of the pembrolizumab arm, in contrast to when CPS was less than one. However, we should be cautioned that only 5% of the enrolled patients were PDL1 negative. So there was the study with this group was underpowered to give any inference regarding the CPS scoring. So the regulatory approval was given independent of PDL1 status. Similarly, uh, here in 1B2 and 2B also the hazard ratio was not so significant, but the confidence interval was wide, which emphasized small sample size and data immaturity was there in this specific anatomical cut. However, because this was post hoc analysis uh, and there was severe unmet need in this group, the regulatory approval was given to all from 1B2 to 4A. And overall safety profile, patient approximately 74%, 75% patient in pembrolizumab arm experience grade 3 to grade 5 adverse event compared to 68% in placebo arm. However, the key toxicities were hematological like WBC, leukopenia, anemia, and neutropenia. The clinical takeaway was the addition of pembrolizumab modestly increased grade 3 to 5 toxicity, but the profile was consistent with well-established individual agent safety profile. As we can see in this temporal progression of side effects, in the first 3 months, the most common side effects were hematological and GI or pelvic side effects like diarrhea, which was commonly seen in CTRT group, even if pembrolizumab was not increased. This is common in cisplatin-based chemotherapy also. Post 3 months, the side effect profile was mostly due immune-related adverse event, which was mostly due to classical pembrolizumab immunotherapy-related immune-mediated agents. So toxicity management must adapt longitudinally as the patient transitions from the intense concurrent phase to the prolonged maintenance phase. Uh, Here we can see the highest incidence of grade 3 to 5 adverse event was hematological and which was deeply intertwined with the known myelosuppressive effects of weekly cisplatin and pelvic radiotherapy rather than novel immune toxicities. Immune-related adverse events mostly were endocrinopathies, thyroid dysfunction. 19% patients in pembrolizumab have had hypothyroidism versus 5% in placebo group, whereas 11% in pembro arm had hyperthyroidism versus 2% in placebo group. Other was hepatic or GI toxicity with AST increased in 18% in pembro group versus only 12% in placebo group. So endocrinopathies, specifically thyroid dysfunction, represented the most significant IRAE in increase, requiring routine clinical laboratory monitoring throughout the maintenance phase. Uh, did the using pembrolizumab resulted in discontinuation or fatalities over and above CTRT? So, this trial showed that this was not true. Treatment discontinuation rates were almost similar, with 15% in pembro group versus 13% in the placebo group. And the discontinuation was in any component of treatment versus like pembro or placebo. There was almost no discontinuation of all treatment. That is, radiotherapy was discontinued, was not seen in almost any patient. Treatment-related fatalities were seen in less than 1% in both the arms. In Pembro, the most common, the two patients were died due to intestinal perforation and gastritis. And in placebo arm, marrow failure and neutropenic colitis was there the cause of death. So, addition of immunotherapy did not compromise the ability of patients to complete their curative intent chemoradiotherapy. So, what is the regulatory landscape? So, this biomarker agnostic approval was granted regardless of PDL1 status. Uh, while Keynote A18 was data was in strongest in CPS more than one, FDA and EMA granted all comer approval due to severe unmet need and broad efficacy observed in the highest population. So it was approved by both FDA and EMA. Now, with this approval came the challenge, which with evolving staging, the challenge came to translate this data into the clinical decision. So, in clinical trial inclusion, FIGO 2014 staging was used, in which stage 1B2 and 2B node positive patients were taken. While now, when we are using FIGO 2018, and there is a discrepancy in those because FIGO 2018 staging was bypassed in trial design because a size and anatomical extension comparison for node positive patients would have been obscured. All patients who were node positive would have been lumped into the stage 3C in FIGO stage 2018, where in comparison to 2014, where there was no such class. So, in the same sense, and this is the NCCN guidelines for cervical cancer, which says that in stage 2B to 4A patients who are negative for distant metastasis, EBRT plus concurrent platinum chemotherapy plus brachytherapy can be used, along with the concurrent and maintenance pembrolizumab, which is category 1 for FIGO 2014 staging, stage 3A, 3B, and 4B, whereas category 2B for select FIGO 2018 stage 3 to 4A patients. So, along with this, I would also like to shed some light over a trial for Kala trial, which used durvalumab in place of pembrolizumab along with CTRT, and enrolled 770 patients. But and the primary endpoint was PFS, which failed to meet the statistical significance. So why the keynote 18 study proved to be statistically significant but not Keller trial? So there can be few factors like target mechanism. Pembrolizumab targets PD1, whereas durvalumab targeted PDL1. Uh, the minimum node size included in Keynote 18 was 1.5 centimeter, whereas in Kella trial it was only 1 centimeter, and there was highly specific node positive inclusion criteria. And in Kella trial, broader biomarker unselected all-comer patient was taken. So different in molecular targets, subtle variation in high-risk patient selection likely drove the divergent phase 3 outcomes in both these trials. As I told you that Keynote 18, the minimum nodal size was 1.5 centimeter, which was included in the inclusion criteria compared to Cala trial, where it was 1 centimeter. So this suggests that Keynote 18 tried to capture more sicker population by requiring larger minimum node sizes, and they may have selected cohorts with a greater burden of systemic micrometastatic disease, making them more primed to benefit from systemic addition of immunotherapy. So this is the current executive summary of the trial. We have a breakthrough in Keynote A18 data, which has significantly improved PFS and OS. However, there is a contrast in the form of CALA trial where durvalumab failed to show any significant PFS benefit, and presently FDA and EMA approval is there with the Keynote A18 for chemoradiotherapy in pembrolizumab. Thank you.
Thank you, Dr. Ashutosh. you have very uh, clearly highlighted like for which subset of patients this new regimen of pembrolizumab and CTRT is useful. And from your presentation, I think every one of us could easily see that majority of them were the PDL1 positive patients, and
Yes,
especially the benefit was more in the stage 3, 4 patients. And
yes,
another important point that you brought out is the FIGO staging. We should all look into it while selecting our patient for this type of regimen, like if they're exactly matching the trial criteria or not, because of
mm.
the obvious cost implications with this drug. So just a quick comment from you, Ashutosh. Which sort of patient you think is, as of now, the best candidate for this drug, this combination?
Uh, However, as we know, the approval is for node positive patient, node positive 2B to 3 and 4A patients. I would be more confident in using stage 3, 4A patient with burden of where burden of disease is more to use the pembrolizumab.
So thank you. And I would like to invite my next speaker, who will be talking on the topic of the sequencing dilemma of induction chemotherapy as in the context of the Interlace trial. And I would like to invite Dr. Praful Pandey, an alumnus of AIMS New Delhi and currently working as associate consultant at Medanta Noida. Dr. Praful, please.
Hello, am I audible?
Yes, sir.
So the slides are visible, right?
Not yet, sir. It's too small.
Are the slides visible now?
Yes, sir.
Okay. So good evening, everyone. I'll be talking about the Interlace study. For a very long time, for carcinoma cervix, especially the locally advanced settings, the only option in terms of therapy that we had was CTRT, with very few of the trials showing any benefit despite a multitude of studies being done. So one Ashutosh sir has already covered, which was the keynote A18. The second study that has been positive in the more recent times is the GCIG Interlace study, which has instead utilized a neoadjuvant chemotherapy only backbone. So why was increasing systemic therapy or intensifying systemic therapy the direction to go in carcinoma cervix? Because when we looked at patients who were being treated with concurrent chemoradiation as the standard of care, while the 70 to 75% of patients were achieving long-term remission, of the patients who were having relapse, overwhelming majority were having distant metastasis, which clearly pointed to the fact that perhaps it is a systemic component of care that we are giving, which is lacking, while the loco-regional control is adequate with radiation. So, in this regard, a multitude of studies were done. The Outback study, the ORT study by Sudeep Gupta sir from Tata, all of them evaluating either adjuvant or neoadjuvant approaches with surgery or radiation. Unfortunately, not only was there no OS benefit, two out of three studies seemed to reduce the disease-free survival or progression-free survival. The most likely hypothesis that was formed on the basis of these studies was that because of the gap that is there between the definitive chemoradiation arm, which remains the most important part of therapy, and the systemic arm that we are introducing, we are providing the micrometastatic disease in the body to grow unchecked for a decent amount of time. And because after that we are giving only concomitant chemoradiation with systemic therapy already over, the distant micrometastasis will at some point of time manifest as stage 4 disease where outcomes will be much more dismal. So keeping that in mind, Interlace study was designed. The schema was very simple. They utilized induction chemotherapy. The way the schema was designed was that One, the chemotherapy backbone should be very easy to tolerate. So it is a standard weekly paclitaxel carboplatin for 6 weeks, and mandated by protocol, the gap between the induction chemotherapy and the initiation of chemoradiation should be less than 7 days. Uh, in the inclusion criteria, what is important for us would be the stage, as was the case with Keynote A18 in Interlay study as well. FIGO 2008 staging was used. So 1B1 with nodal involvement or 1B2 onward. So any macroscopic growth 4 centimeter or larger, or macroscopic growth visible less than 4 centimeter but having no evidence of nodal involvement on imaging. As long as these criteria were met, these patients were eligible for the study. The trial population was very representative, with 70% patients having stage 2B disease, 43% having pelvic node positivity, 80% having 82% having squamous cell cancer, and the median largest lesion being 4.8 centimeter in the enrolled population. So, first talking about the feasibility, when we say that the protocol mandates that within 7 days you have to initiate chemoradiation, 78% patients were able to achieve the transition within 7 days, while 17% achieved the transition within 8 to 14 days. So, what this tells us that whatever the result may be of the trial, the hypothesis that the gap between systemic and local regional therapy has to be minimized was met. And another thing was, when we look at therapy completion rates, even though only 84% patients were able to complete their prescribed weekly paclitaxel carboplatin, the rates of completion of CTRT were 98% and 97% in uh, intervention and control arm respectively, with not much, no statistically significant difference in patients receiving 4 or more cycles of concurrent cisplatin with radiation. So what this tells us is that by adding induction chemotherapy of this particular regime, uh, mostly patients are not at a risk of not being fit for concurrent chemoradiation subsequently, and there is no impact on the rate of completion of radiation, on the relative intensity of radiation, radiotherapy delivered, or the intensity of concurrent chemotherapy delivered, as we can see from this graph. So, based on this schema, when we looked at the progression-free survival, which was the primary endpoint of this trial, we can see that we have a hazard ratio of 0.65, which is statistically significant, having an absolute difference of 8% at a follow-up of 5 years in landmark analysis, which is significant and at par with what we achieved with chemotherapy addition in head and neck cancer or in breast cancer. More importantly, overall survival was positive in this study, with a 60-month, that is 5-year landmark, showing a 12% improvement in the intervention arm as compared to 18%, sorry, as compared to the control arm, which is a 40% relative reduction in risk of death from carcinoma cervix, again statistically significant. And keeping in lieu with the hypothesis that was made that it is the distant micrometastatic disease that is failing, when we look at the mechanism of or the type of relapses in patients in the intervention arm, only 12% are distant only relapses in control arm versus 7% in intervention arm. So the reduction in relapse that is being seen is mostly seen in distant relapses, while the local regional control efficacy remains the same. Toxicity was manageable, as we have all experienced when we give weekly paclitaxel carboplatin. Grade 3, grade 4 neutropenia in 19% only, anemia in 5%, thrombocytopenia in 5%, and non-hematological grade 3, grade 4 in 44%. So what another thing is that because this trial was so heavy on the intensity and the duration and the completion as the quality markers, GCSF was not only permitted but very much recommended. So in the trial schema, you will see that even if there is one episode of grade 3 neutropenia during the induction period, in subsequent cycles, GCSF is added by its own. We don't wait for any febrile neutropenia or grade 4 neutropenia or any delay in therapy or reduction so as to initiate GCSF, so that patients can complete their weekly paclicarbo and go on to CTRT in the least possible time possible. As is expected, because we are adding 6 weeks of chemotherapy, there is a transient drop in quality of life, which was assessed by a global QOL scale, URTC QLQC 30. But the mean change from baseline was only 5 units. So, as you all know, the scale is using 4 subdomains and then linearized to 0 to 100. So, a change of 5 from baseline is not clinically relevant for the vast majority of patients. And not to mention that as the therapy goes by, there is no impact on the chronic quality of life, which was one concern because we were adding paclitaxel and neuropathy could have been something that could stop us. So uh, I will. So apart from Keynote A18, we also have the option of interlace now for carcinoma cervix patients who are destined to go for CTRT. The slide is just to show the difference and perhaps how to choose which protocol to go for whom. Of course, interlace regime would have the advantage of being independent of PDL1 status, being much more inexpensive and universally available, and inclusion of a broader cohort, standard and high risk, and subgroup analysis showing benefit across all the group. But as mentioned in the previous presentation, both the studies were positive. Both had an improvement in their primary outcome. And perhaps in future studies will tell us how to incorporate both of these changes in treatment planning of carcinoma cervix to further optimize outcomes. Thank you.
So, thank you, Dr. Praful. Here is a very important fact that is coming up is how to decide like for which patient we should give the keynote A18 protocol versus the interlace trial. And very clearly, Dr. Praful has shown us that the keynote A18 was predominantly for the nodal positive, the more number of nodal positive, especially the para-aortic nodal involvement was there in the keynote A118, whereas the interlace trial have excluded those set of patients who we should all keep this in mind while selecting our patient, which is obviously irrespective of the cost constraints here we're talking. So, Dr. Praful, just this small question from you. According to you, what is the key factor in determining like which patient should go for the which type of regimen?
Of course, if cost is not a concern for us, then the most obvious answer would be PDL1 status and the burden of disease, which was different in both the trials. Apart from that, I would also say that for the vast majority of patients, tolerating immunotherapy is mostly going to be easy, which while this may not be the case for a lot of patients who are receiving weekly paclicarbo. So if we are faced with a patient where we feel that this weekly induction regime can really jeopardize their capacity to start CTRT at a timely point, then we can also lean harder for immunotherapy in those patients. Otherwise, mostly based on disease burden and PDL1 status and affordability, we should decide.
Yeah. Thank you, Dr. Praful. I would also like to request all our participants, our attendees, and the panelists, if you have any questions, please kindly put it in the chat box. We will take it all the questions at the end of the session or during the panel discussion. And we will be rediscussing this issue of how to select between interlace and keynote A18 when our moderator, Dr. Sashank Bansal, will be taking up the panel discussion. So now we will be moving forward, and I would like to call upon my next speaker for Dr. Deepak Mittal, sir. He is a radiation oncologist and director and head of radiation oncology department at Medanta, Noida. And he will be talking on the advanced radiation technology, the uses of the IMRT and the image-guided brachytherapy in cervical cancer. Dr. Deepak, sir, please.
Hello, good evening, everyone. Am I audible?
Yes, sir.
Good evening, everyone. I am Dr. Deepak Mittal, and today we are discussing about the advanced addition technologies, IMRT and IGBT in the CA cervix. As usually, it is a very vast topic. I having the very little time for this, so I will try to complete it as early as possible. So, come to the topic. The CA cervix is the most common, one of the most common malignancy in the females, either globally or in India. Globally, it is the fifth most common malignancy, and approximately more than 6 lakhs new cases are coming annually according to the Globacon 2022. This is the second most common malignancy in Indian women, and in India, most of the malignancy, most of the cases, more than 70% of cases are coming in the locally advanced stage. So for this, the CTRT followed by brachytherapy, the treatment of choice. This is in this picture, we can see the evolution of the radiation therapy delivery from the 2D era where the bony landmark based radiation planning was done. Now in the mid 2000, we are coming to the IGMRT or IGRT. And in the brachytherapy, from conventional point based brachytherapy to the image guided adaptive brachytherapy, we are heading towards. Now we come to the IMRT. This is the intensity modulated radiation therapy. This is the advanced technique of the conformal radiation therapy, which use the non-uniform radiation beams intensity to tightly sculpt the dose distribution around the target volume, whatever the complex shape of the tumor it is, and aggressively sparing the critical adjacent healthy tissues. The core concept of the IMRT, which we can see here in this picture also, inverse planning and the fluence modulation is there. Here we can see in the IMRT, there is the very highly conformal dose distribution around the target with better sparing of the OARs. Why? What it is? The principle of conformal radiation therapy, there is the multiple modulated beams are there. Basically, beams intensity not modulated. This is the fluence modulation is there. And we are having here the inverse planning. With the help of multi-leaf collimator, we are modulating the fluence of the beam, and we are achieving the steep dose gradients with the help of this, by which we can achieve the high dose to the CTV with rapid fall off of the dose towards the adjacent healthy normal tissues. So in the CA cervix, the rationale for the image guided intensity modulated therapy is because the target complexity in this area, in the CA cervix, cervix parametria and pelvic parietal lymph nodes makes a irregular target. So this is the very complex target by which, with the help of the IMRT, we can target the area very effectively in the conformal way. The lot of organ motion is there. The interfraction and interfraction motion is there. So we can I easily handle with the help of the image guidance in the IMRT. We can escalate the dose if there is any parameter, we want any parameter boost, or there is any node clinically or radiologically palpable node is there. We can boost that node easily. That is simultaneous integrated boost. That is possible with the IMRT. And at the same time, because of the rapid dose follow-up, we can reduce the toxicity profile also in the surrounding normal tissues. So benefit and limitation of the IMRT is, benefit is better sparing of the surrounding normal tissues. We can spare the bone marrow also. We can do the simultaneous integrated boost in the same volume, in same number of fraction. This is a more conformal plan with superior target coverage. But there are limitations also, because IMRT without image guidance is not good because of the lot of organ motion is there. So image guidance is very much mandatory. And with the IMRT, because we are having the multiple modulated beams, so volume receiving the low dose around the target is very high. So high integral dose is there. A very complex plan and technical expertise is needed in this IMRT. Here we can see in this picture, this is the 3D CRT and this is the IMRT plan, where we can see the conformability of the dose distribution very high in the IMRT arm with better sparing of the normal tissue where it is bladder is there. There we are effectively sparing the bladder from the target dose. And in the second volume also, this is the 3D CRT and this is the IMRT picture where we are effectively sparing the surrounding normal tissues and achieving the target dose around the tumor area. In this, what we can see here is that we can do the simultaneous integrated boost to the nodal area. This blue area is the targeted prescribed dose, and this orange area where we want to give the extra dose. We can do that with the help of IMRT. This is known as simultaneous integrated boost. So step in the IMRT implementation is that first we have to immobilize the patient and then do the simulation. The most important thing one is the bladder protocol. Organ filling protocol is very much mandatory in IMRT in the CA cervix. is in it, we ask the patient to pass the urine in the clinic and then take the some amount of water. And when patient will have the first surge of micturition, we will take the CT scan. And the same thing we have to repeat at the time of treatment also, by which we can produce the same geometry of the bladder every day. And that will be the small bowel and the large bowel will be out of the radiation path, the side effect will be less. And at the same time, the target precision will be high. And the percentage of the bladder, which will be covered by the target dose will also be less. After immobilization simulation, we have to contour the target. And this is the bladder protocol. Here we can see the empty bladder, and the last slide there's a full bladder where we can see the bowel bag is far away with the full bladder, by which the dose to the bowel bag will be less, and the side effect chance of the like loose motion and everything enteritis will be less in the case of IMRT. After doing the contouring, we have to do the treatment planning, quality assurance, and the daily treatment delivery. In the treatment delivery, we have to reposition the patient in the same geometry and with the bladder protocol. After with the image guidance, there are different techniques of the image guidance are there. KV, CBCT, KV imaging is there. CBCT right now we are having the surface guided radiotherapy also, and MRI Linac based image guidance is also there. In the CA survey, why image guidance is required? Because there interfraction motion are there. There uterine cervical shift is there. The movers and non-movers patients are there. And the bladder volume variation can be there. So we have to identify that also. The rectal distension can vary on the day-by-day basis. And interfraction motion is there. So image guidance is very much important in the CA cervix malignancy. These are the image guidance modalities: KV, MV planar imaging, cone beam CT scan, surface guided radiotherapy, and MR Linac based real-time adaptation we can do on the MR Linac. This is the target volume delineation of the IMRT. There are several guidelines for the target volume delineation for the CTV. For the definitive, this is the guideline from the Karen Lim et al. The consensus guideline delineation of the CTV for the intensive radiotherapy for the definitive treatment of cervical cancer, which was published in 2009. And for the adjuvant setting, post-operative treatment for the cervical cancer, Small et al. Give the guideline for the same for the CTV delineation, the IMRT in 2007. The PGI guidelines are also there, where we can see in this picture that the CTV is delineated. This is the uterus, the cervix, the vagina. This is the parametrium with the red color. In early stage, up to the 3A, second B, 3A, we have to posterior boundary of the parametria of the CTV is the anterior 1/3 circumference of the rectum. But if the disease is 3B and more, and if the uterosacral ligament is involved and the lymph node involvement there, we have to cover the whole mesorectum. Here we can see in the G image. And for the lymph node contouring, Taylor et al. Gave the guidelines in the 2005, where we have to contour, give the specification for the and the recommendation for the contouring of the different station of the lymph node, like common iliac, external iliac, obturator, internal iliac lymph nodes, and presacral lymph nodes. Where here we can see on this picture how we have to contour the lymph nodal area in the CA cervix. In this picture, we can see this is the common iliac lymph node, the external iliac, internal lymph node. This is a presacral and obturator lymph node, and this is the orange color structure, the parametrium. Now the evidence in the favor of the IMRT is that there is a trial. It is a phase 3 randomized trial where we compare the 3-dimensional conformal radiation therapy with the image-guided intensity modulated radiation therapy in locally advanced CA cervix by B. Rai et al. It was published in the 2024. Included the stage 2 to 3B patient without pelvic lymph nodes. Number of patients was 173, equally randomized in 3D CRT and IMRT trial. The median follow-up was 61 months. Primary endpoint was the grade 2 or more acute toxicity, and second endpoint was the grade 2 more than grade 2 late toxicity, and the overall survival PFS. Here we can see in this trial, the overall survival PFS and the late toxicity, there was no significant difference. But the acute toxicity, especially for the dermatitis grade 2 and more, the proctitis grade 2 and 3, and the cystitis grade 2 and 3, there was significant difference was there. In the IMRT, IGRT arm, the chances of grade 3 dermatitis was 7.14%. In compared to the 3D CRT arm, there was 20% of the patient having the dermatitis. In the proctitis, only 1.2% of the patient in the IMRT arm versus 4.5% patient in the 3D CRT arm having the grade 3 and more toxicity in the rectum. And the same other trials are also there. For the definitive setting, Gandhi et al., Yu et al., and Naik et al., which perform the randomized control trial, which are these all trials are showing the same results with they are showing the better toxicity profile all in the IMRT technique with without any compromise in the disease-free survival, overall survival. And the adjuvant setting also, the time C trial is there and the parser trial is there, which are also showing that there is the toxicity profile was better in favor of the IMRT, while without any compromise in the disease control. Parser et al. This showing the grade 2 toxicity, any late grade 2 toxicity, 24.5% in the IMRT arm as compared to the 3D CRT arm, there 40.9%. There is the more than 40% reduction in the toxicity was there with disease control was the same. Like this, the Intertech 2 and Intertech 3 trial, these are the bone marrow sparing trial, where we compare the bone marrow sparing IMRT with IMRT, conventional IMRT. And what we can see here, the bone marrow sparing IMRT, the grade 3 neutropenia was 8.6% only in compared to the conventional IMRT 27.1%. So we can spare the bone marrow effectively also, by which hematological toxicity will be less in IMRT arm. Several other ongoing trials are there. RTR cervix trial, which are evaluating the daily adaptive radiation therapy on the MR-Linac based radiation therapy there. We can daily adapt the radiation dose, limiting by which the limiting dose to the damage to the health tissue, the bowel and bladder is there, and the heroic trial is there. This is the hypofractionation trial. There are other several trial are there like POHIM P3 trial, heroic trial, and the Swift 1 trial, where we are analyzing the role of hyperfractionated RT in the CA cervix, by which we can reduce the treatment time to the 3 weeks in compared to the 6 to 8 weeks, and with the same control of the disease and with same toxicity profile. Now, so in nutshell, the IGMRT is preferred over the 3D CRT either in definitive setting or the adjuvant setting because it has a significant reduction in the toxicity without compromising the disease control. Now we are coming to the image-guided adaptive brachytherapy. So brachytherapy is the important component of the treatment of the cervical cancer. Here we are having the 2D brachytherapy, which was point-based brachytherapy. Now we are moving towards the image-guided brachytherapy for the better coverage of the tumor. Why image-based brachytherapy is required? Because point-based brachytherapy, the point A is not a fixed point, fixed point, because it may change, it may vary because of the position of the tandem, and it may overestimate or underestimate the tumor dose. Larger tumor needs the greater optimization dose of the proper tumor coverage, not possible the point-based dosimetry. So we are moving towards the image-based brachytherapy. What is the benefit? We can check the proper geometry of the application, delineation of the tumor and ORs is possible, and the dose optimization and reliable dose option we can see effectively. And Kim et al. Found that he has stated that the dose to point is significantly lower than the D90 of the HRCTV. We can see in this picture that if we are doing that point-based brachytherapy in the standard loading, here this blue color is the GTV. This is the HRCTV basically. If we are doing the point-based brachytherapy, this area, the outside area out of the solid red line will get the lesser dose. That is not covered in the prescribed dose. But if we are doing the image-guided brachytherapy, we can optimize to the dose to this area, and this dotted line is the dose distribution where we can cover the whole HRCTV effectively with the help of image-guided brachytherapy. What are the steps? Now is the steps in the IGBT. What is pre-implant evaluation and the patient preparation is there. Then applicator selection and insertion, image acquisition, then delineation and prescription, planning, evaluation, and treatment delivery. After doing the pre-implant evaluation, patient preparation, and applicator selection, after insertion, we have to take the image acquisition. In it, what we can do the CT scan or MRI. CT scan is basically this is a widely available imaging. So we are usually using, most of the center we are using the CT scan itself, but we cannot identify. There's a limitation of the CT scan because we cannot identify the GTV. We cannot differentiate between the uterus, cervix, and peritoneal tissue, sigmoid colon itself. So usually most of the time we overestimate the tumor contours compared to the MRI. Ideally, we should use the MRI for the better delineation. The MRI scan, the advantage is excellent soft tissue contrast, better visualization of the tumor, parametrum, and the can differentiate with the uterus, cervix tumor, and OARs. More useful in the advanced and infiltrated tumor. And the disadvantage because they require the special applicator for the MRI, and that should be the MRI compatible applicator. It is very expensive. In the MRI, there's a poor bony anatomy distinction, and we have to need to fuse the CT scan with the MRI for the planning. Some motion artifact can be there in the MRI. These are the Jack Astro recommendations which were published in 2005 by Herr Mather et al. And they recommend the what we have to contour in the after inserting and taking the pictures of the brachytherapy patient. Here we can see uh, they are the different volume. The HRCTV, IRCTV. The HRCTV high risk CTV and the IRCTV the intermediate risk CTV. HRCTV includes the cervix and the residual disease at the time of brachytherapy. We have to contour. If the complete remission is there, so we have to contour the cervix, whole cervix in the HRCTV, and take the 1 centimeter margin for the IRCTV around the cervix. But the most important thing is we have to uh, we have to include the initial GTB volume initial at the time of diagnosis in the IRCT, where we can see in this picture we are including this is the margin is more than 1 centimeter. If the partial response is there, we can see here cervix and this residual disease there. We can take that 1 centimeter margin all around the HRCTV to generate the IRCTV. These are the recommendation of Jack Astro working group, the concept and terms in 3D imaging based treatment planning in service brachytherapy. What we have to record as per what we have to record, we have to record the D90 of the GTV, HRCT, and ISCTV, and the for or OARs, we have to record the D.1 cc, D1 cc, T2 cc for the OARs. And sometime if we are contouring the organ wall of the organs only, so we have to uh, record the D5cc and D10cc of the wall of the organ. What are the recommended dose prescription is there? The HRCTV dose, it should be equivalent to should be 85 to 90 gray. IRCTV dose should be equivalent to the more than 60 gray, and target coverage D90. D90 is 90% of the volume. Dose to the 90% of volume should be equal to the 100% of the prescribed dose. And for the organ at risk, the bladder D2cc should be less than 90 gray, and D2cc for rectum and sigmoid should be less than 70 to 75 gray should be there. So what is the advantage of IGABT? There is a superior tumor target because we have the imaging. We can easily contour the target with the help of MRI. We can optimize the dose, and we can see the dose distribution, so we can spare the surrounding organs very effectively. Yes, because we are having the better tumor target, but better tumor dose optimization, we are having the higher local control and survival, and the long-term toxicity will be less in the IGABT arm. But there are limitation of the IGABT is there because there's a high resource demands is there. We need the MRI and the 3D imaging is there. Limited MRI availability. So we are not able to do the MRI based IGBT in the most of the centers. So, but right now, the most of the center we are doing a CT based IGBT, image guided brachytherapy. And this procedure takes the more time in compared to the conventional brachytherapy. These are the studies which are the building the evidence for the IGBT. Initially, retroembrace study was done. This is a retrospective multi-center cohort validating the early MRI IGBT experience. It includes 730 patients. But in this study, only 9% of the patient had the IMRT. Median follow-up was 43 months, very good. 5-year local control was 89%, and the overall survival was 65% with lesser grade 3 to grade 5 toxicity. Only GU was 5%, GI 7%, and vagina was 5% toxicity were there. After that, the Embrace 1 study was started in 2008. Accrual was started in 2008 and completed in 2015. This is the study was done to validate the Jack-Astro recommendation, and at the same time, to provide the benchmark for the IGBT and to present the reference material for the treatment parameters and to introduce the MRI-based image-guided adaptive brachytherapy. This study was formulated, and in this study, there were 1,416 patients were there. In Embrace 1, only 41% patient of the had the IMRT for the external beam radiation therapy. For this, median follow-up was 51 months. 5-year local control were very much high income. The 92% local control was there, and overall survival was 74%. Disease-free survival was 68%. Nodal control was also very good. 93% at 5 years for the N0 disease, and for the N1 disease, it was 81%. The 5-year grade 3 to 5 toxicity in the GI 8.5%, GU 6.8, and fistula was 2.2% was there. Grade 4 toxicity in the Embrace 1 study was somewhere around the 4% is there. In Embrace 1, what we see that 21% of the patient who are having the lesser response by the EBRT, where the dose optimization, very high dose optimization required. If we are doing the point A based uh, dosimetry, point A based brachytherapy in this, the point A will receive the lesser dose in compared to the actual HRCTV volume. Now, after that, in the 2016, the Embrace 2 study was started. This is the prospective interventional study in which the 1482% were included. But the main aspect is that 100% of the patient received the erectional beam radiation therapy by IGMRT technique. Its interim results was presented at ISTRO 2025. The median follow-up was 39 months, and the very good local control and overall survival. 3-year overall survival 87%, local control 193%. The grade 4 toxicity was less than 1% in Embrace 2 study. In compared to the Embrace 1, where it was the 4% only. Right now, we are having the randomized control trial which compare the conventional brachytherapy to the MRI-based brachytherapy in locally advanced CS cervix. It is a phase 3 randomized trial going on. The accrual is completed in 2025. 1,050 patients were included, but results were awaited. In the combat cervix trial, the hypothesis was the MRI-based brachytherapy. The absolute increase in the local control of 10% and reduction in the late GI GU toxicities by 5 to 10% as compared to the conventional brachytherapies there. This is the dose planning games from the Embrace 2 study. The HRCTV D90 should be at least 85 gray EQD2. Ideally, should be between the 90 to 95 gray. Bladder 2 should be less than 80 to 85 gray. Rectum and sigmoid should be less than 70 to 75 gray. And overall treatment time should be less than 7 to 2 days. Ideally, like Embrace 1, we have to complete the treatment in the 50 days. This is the take-home message. The conclusion, for the locally advanced CA cervix, the concurrent platinum-based chemoradiation is the remained standard of care. Wherever possible, IMRT with image guidance should be preferred over the 3D CRT because it reduces the acute and chronic GI and hematological toxicity without any compromise in the disease control. For the image-guided brachytherapy, MRI-based image-guided adaptive brachytherapy is preferred over the conventional brachytherapy approach too, because we can cover the target tumor area effectively and we can save the surrounding normal tissue effectively. The overall treatment time should be minimized, and because the prolonged treatment course are associated with the inferior local control, we should complete the treatment in less than 7 to 8 weeks. Thank you.
Thank you, Deepak sir, and I must congratulate you that in this short span of time you have covered almost all the important trials for both the IMRT as well as the image guidance brachytherapy. So a very quick question to you, sir. In your experience for IMRT over 3D CRT, which toxicity you have seen has been brought down with the help of IMRT? And similarly, the same question is for the image guidance brachytherapy.
Basically, the IMRT, specifically the gastrointestinal toxicity, are very much reduced. More than half reduction, more than 50% reduction in the GI toxicity is there. It's one trial by the B. Rai et al., which was published in 2024, which is showing the acute toxicity like cystitis is also reduced significantly. P-value was significant for that. But ideally, most of the studies showing the reduction in the GI toxicity is there. And for IGBT, in the IGBT, what is the benefit of IGBT is that the local control, pelvic control, and the oval survival, everything is improved with the help of the image guided brachytherapy. But at the same time, the reduction in the GI GU toxicity and the vaginal toxicity very much less. And in the advanced stage like the 3B and 3A, 3B and above, the chances of vaginal fistula is there, which is very much reduced, less than 1% in the IGBT arm, which is showing in the Embrace 2 study.
Thank you, sir. Since these are very important topics that we should all be aware, because at one end we are trying to escalate with the uses of the NSCT or the immunotherapy. So this, like for example, the Keynote A118 has mandatorily made an inclusion criteria that all their patient would undergo a 3D, a three-dimensional imaging-based brachytherapy and not the point A-based brachytherapy. So thank you, sir. Thank you. And now I will move on to the
Thank you
next
very
session.
much.
I would like to invite my dear colleague for Dr. Apurva Tak. She is a gynecologist currently practicing at Bhagwan Mahavir Das, and she will be talking on the surgical de-escalation and innovation in cervical cancer. Dr. Apurva, please. You are mute, Dr. Apurva.
Hello. Hello. Good evening, everyone. Satyabas, am I audible?
Yes,
Yes,
sir.
yes.
Yes,
Now,
ma'am.
now you're audible.
Yeah. Good evening, everyone, and I congratulate Dr. Satya Sarangi to have, compiled so nicely this comprehensive webinar on cervical cancer. I'll just share my screen 1 minute. So is my screen visible? Is my screen visible?
Yes.
Yes,
Yeah.
ma'am.
So my topic is actually just a minute. Second. We'll be discussing on the surgical aspect of treating cervical cancer. And in this era, basically, two major things have happened in the field of cervical cancer. One is definitely surgical de-escalation, which I'll talk about in terms where and all we are actually de-escalating. And the second important thing is innovation, rather, what has particularly changed in the management of cervical cancer, how MIS has been buried, and how open surgery has taken over. So, so why de-escalation is the first point. How it all started. Why do we actually need to, go from radical hysterectomy to a more conservative, simple hysterectomy or conization? So it was seen that, while maintaining oncological safety, while reducing morbidity, can we actually improve the survival at the same time? Because, with radical hysterectomy, the more radical we were, there were more, side effects with regards to bladder dysfunction, sexual dysfunction, lymphedemas, fertility loss. And at the end of the day, what matters most, why we are doing all these immunotherapies and why we are talking about such advanced radiotherapy is because we want to improve the quality of life of our patients. So now, where are we de-escalating? So the first point was why we are de-escalating, and now where actually we are de-escalating. So we are moving towards less radical hysterectomies, more fertility preservation surgeries, less of comprehensive lymph node dissections in form of sentinel lymph node mapping, which has also come in cervical cancer. And so the objectives with this presentation is we are going to review the landmark trials pertaining to all these topics. And yes, when we talk of innovation, we'll actually deal with where MIS has gone after coming in of LAT trial. So this was it. We had radical surgeries in 1900s. There were various modes in which radical hysterectomy actually took over. And then this era of beginning from 2021 actually started, wherein we first had the CONSERVE trial, which looked into the feasibility of doing a less radical surgery. The feasibility study, which was the CONSERVE trial, and then came in the randomized control study in the form of a non-inferiority trial, the SHAPE trial, and then finally the lesser trial. So quickly looking into these trials. So the CONSERVE trial, which came in 2021, was a multi-center prospective single-arm study. And the population they had selected was classically tumors of 1A2 and 1B1. So mind you, it was the FIGO 2018 classification, wherein 1B1 is definitely less than equal to 2 centimeters. And then negative margins, LVSI absent, node negative patients, They had enrolled some 100 patients in this study, and what they looked into was whether conservative surgery in terms of conization or simple hysterectomy with pelvic lymph node dissection vis-a-vis sentinel lymph node biopsy, was it equivalent to the other surgeries we were doing. But it was, mind you, it was a single arm study. There was no comparative arm. They simply looked into the feasibility, and the primary endpoint was recurrence. Now, what they found, the remarkable results, which actually paved way for a randomized control study, was that the residual disease even after conservative surgery was just 2.5%. The recurrence rate was just 3.5%, and the overall survival and cancer specific survival did not deteriorate with this conservative surgery in this subgroup of selected patients. So, this study actually demonstrated that for these all, selection criteria patients, conization or simple hysterectomy was actually feasible. And this was where the first concept of surgical de-escalation began. Then came the remarkable trial, which actually practice changing trial, I would say, the SHAPE trial, which was published in the New England Journal of Medicine in 2024. Now, this was a multi-center randomized trial, and mind you, in having a randomized control trial in cervical cancer, wherein the operable cases are as such very less, with a number of patients amounting to somewhere around 700 patients, is quite rare. And we had this randomized trial evidence which strictly said that in patients with FIGO 2018 1A to 1B1 stages, tumor less than 2 centimeters, stromal invasion was another criteria which they included, less than 10 mm in MRI, and node negative patients, when you talk about them, they had two arms. The intervention arm, wherein simple hysterectomy and pelvic lymph node assessment or sentinel lymph node biopsy was done, and the control arm had radical hysterectomy and pelvic lymph node assessment or SLN. Their primary endpoint was pelvic recurrence at 3 years, and the secondary endpoint were oncological safety parameters in form of DFS, OS, surgical morbidity, bladder dysfunction, and everything else. And yes, this was the trial. As you can see, the pelvic recurrence, there is no difference. The non-inferiority has been achieved. The OS and the DFS was similar. And to add to this, the quality of life in terms of major surgical complications obviously were less with simple hysterectomy. All the side effects, the bladder dysfunction, the sexual dysfunction, the quality of life were actually better with simple hysterectomy, and then without compromising the oncological safety. So this was a practice changing message we had in 2024, which was after which in NCCN, in ESGO recommendations that we follow in gynae oncology, this came in that for these patients with less than equal to 2 centimeter tumors, negative nodes, no parametrial disease on MRI, stromal invasion less than 10 mm, squamous adeno or adenosquamous histology, you can go in for simple hysterectomy or conization when fertility sparing is actually required. So then came the lesser trial. Again, it was built on the same principles, and it was a prospective multi-center study, which we recently had the results out, and it has further told us it has reiterated what the SHAPE trial has said. And then this is what we have in surgical de-escalation. While CONSERVE was a feasibility study, SHAPE established the non-inferiority, and lesser trial, a prospective international study, further validated whatever has been told by the SHAPE trial. So we are clear with this subgroup of patients that we have de-escalated our surgery in them. Next comes in where else we have de-escalated. Then a very important subgroup of patients now come in wherein fertility preservation is required, which is a very, very important aspect of we as gynec oncologists treating cervical cancer. And here, we used to have radical trachelectomies where the preterm birth rates were very high. Then came in simple trachelectomy. Then came in conization. So now conization was alone sufficient for these subgroup of patients that I have mentioned. These are the same subgroup of patients which have been told in the CONSERVE trial. And now we are further looking into Contessa Neocon F study, which will further see if we can do neoadjuvant chemotherapy shrink the tumors which are more than 2 centimeters and still perform fertility preservation in them. So we are de-escalating in this format. We have reached up till conization, and we are awaiting the results of Contessa trial for neoadjuvant chemotherapy to further de-escalate treatment in patients with tumors of 4 centimeters or more in size. So, and wherein all it began, what formed the framework of us discussing de-escalation fertility preservation was this analysis, which said that non-radical fertility sparing procedures are feasible in tumors which are less than 2 centimeter in size, but not in more than 2 centimeters wherein recurrence is higher. So with all this, we have these criterias, and also very importantly, the ESCO 2023-24 recommendations, the latest ones which we follow, have clearly stated that in HPV-associated adenocarcinomas, yes, you can do fertility sparing, but not in HPV independent variants. So this is a very novel concept, that now we also use the HPV dependence and independence as a criteria for undergoing for practicing the de-escalation. So these are just the guidelines. Now coming into the third most important area where surgical de-escalation has happened is in lymph node dissections. So we know lymph node dissection is associated with a lot of lymphedema, a lot of lymphoceles, and definitely this affects quality of life. And now in cervical cancer as well, we have the CENTIC study and the CENTICOL 1, 2, 3, which have actually established that sentinel lymph node biopsy is feasible. So now they say, where in all do you inject? So these are the sites where we inject. So this has come this has come in and has been incorporated in the latest NCCN also. And they have told that, the major site where you find the sentinel lymph nodes is actually in the superior part of the obturator fossa. And this is the most common site. So now with these Sentinel series, wherein Sentinel 1 told us that, yes, can we detect sentinel nodes accurately? It said yes, that accuracy is there. Sentinel 2 results are also out, which have told us that can we omit pelvic lymphadenectomy? Yes, they have given us short-term survival outcomes. They have said that morbidity is less and the survival outcomes are equivalent. But yet again, we are waiting for the Sentinel 3 study to actually tell us whether SLN biopsy can be adopted as a global standard. So without going into much details of these studies, the Centix was the first one, and it told us that sentinel node frozen section is not a very reliable tool, and that it also told us that SLN can be practiced in tumors less than 4 centimeters. Okay, this was the first concept of SLN which came in 2020. Then we came up with the Senticol 2 trial 4-year follow-up results, wherein it established that, where it established that SLNB versus SLNB plus PLND, the short-term results which it gave, it included tumors 2A1. So that is, it has included tumors less than 4 centimeters. So mind you, sentinel lymph node is only for tumors which are less than 4 centimeters. Obviously, where we actually practice any sort of surgery. So they told us that the DFS and OS is similar short term, but however, we are awaiting the Senticol 3 results. Now, so this is the NCCN algorithm which has adopted SLN. And now the most important, the other part of my talk is innovation in cervical cancer. So rather innovation, I would say the bomb which actually blasted was MIS. MIS was rampantly practiced across all centers for cervical cancer, but then this LAC trial happened, which strictly, told us to abandon laparoscopy for cervical cancer staging. And what actually, why LAC trial or why any sort of MIS could have led to such peritoneal recurrences and such hazardous overall survival in cervical cancer patients. They said that, when you open up the vagina, you do a lot of tumor spillage. The cervix is totally exposed into the abdominal cavity, which leads to the dismal survival and peritoneal recurrences, which were seen in cervical cancer. It could be due to the uterine manipulator. It could be due to the intracorporeal colpotomy. Some people said that it is because of CO2 effects. So then the whole series of, so we LAC trial told us that okay, laparoscopy or robotic is not good. Now they started that what actually is causing this, and can we bring in robotics or MIS again. So with this came in the SOCOR study. The SOCOR study actually told us that MIS increases the risk of relapse, and if you avoid the uterine manipulators and certain vaginal closure maneuvers that it told us about, that if you use these, then actually we'll be able to reduce the recurrences. So then we had the Sucker cone study. It said that these patients where you do a conization, so basically where you remove the cervical tumor and then you perform a MIS, so then again there is it lowers the risk of any sort of relapse. So the Sucker cone study told us this, and the Sucker risk study told us that tumors who are less than 2 centimeters on pre-op imaging, you can operate them with MIS approach. But let me tell you that all these SOCOR studies which were actually working, whether we can bring in MIS or retrospective designs, we are yet to have results of some randomized control study which can actually allow us to practice MIS once again. So yes, we do have a trial. We have the RAC and the ROC trial going on, and we have the early results of the RAC trial, which is the robot assisted approach, which was recently out in 2026, which has said, short term, they have told us that early perioperative and oncologic outcomes have suggested that if you don't use uterine manipulators, if you use a protective vaginal closure and you use a no touch technique, then yes, robotic surgery may be performed in cervical cancer. But yes, these are early results. We are still waiting for a full and final yes or nod from the ROC and the RAC trials before practicing MIS for cervical cancer. So then again, we are having these Contessa and Parola trials ongoing. And they are looking into innovations in cervical cancer, which I've already discussed. And without going into much details, so the clear message that we actually have, the take home message is this: these are the trials which have changed the surgical landscape in cervical cancer. And I hope I have been able to complete in time. So I'll be happy to answer any questions, and thank you so much for the opportunity.
Uh, Thank you, Dr. Apurva. Very well and nicely concised and organized presentation you have made. I'll be just asking you two quick questions because of the lack of time here. First question is, since you told us that with the minimally invasive surgery techniques, there is a lot of increase in the recurrence rate that we have seen, and that requires a lot of skill, like the no-touch technique and no non-uses of the uterine applicator and all. So I want to know how common is this in your gynec-onc fraternity? Like people are used to this. Like how, I want to know the real-world applicability of the SHAPE trial because in the
Definitely.
SHAPE trial, they have, I think, utilized the robotic and laparoscopic in more than 50% of the patient. So what is your take on that?
So, sir, because you've mentioned gynae onco, across all our gynae onco community, we are very strongly not performing MIS. But yes, there are some centers which are doing, the maneuvers which I told you, closing the vagina either with the vaginal cuff closure technique or they're using staplers also. So with following these criteria, some centers, very few of them are practicing MIS, but largely definitely not. We as gynae onco communities, we are not still into MIS for cervical cancer. We are not practicing mostly. Like if you talk of the TMH and all, we are not actually doing it.
And my second question was for the SHAPE trial, do you recommend for this the small cell neuroendocrine histologies only, or you'll strictly limit yourself to the squamous and like the inclusion criteria?
So, boss, actually, with the conservative approach, though the SHAPE trial did not, actually take a neuroendocrine into this thing, and they are very rare tumors and very rare to find them in operable stages. Neuroendocrine always comes in advanced stage. But if you ask me, for such aggressive tumors, I don't think the conservative surgery, if at all we get some tumor which is in operable stage, that to neuroendocrine, I think we'll go in for a radical approach. Conservative surgery won't apply to it, though looking into histology, nowhere else they have, given these ways, but in SHAPE trial, this was not included. So, and looking into the dismal prognosis of neuroendocrine, if at all it comes in an operable stage, I'll definitely go ahead with the radical approach for same.
Well noted, Dr. Apuva. And now I'd like to move to our next session, and I'd like to invite Dr. Rajan Yadav, sir. He is Associate Professor at GCRI Ahmedabad, and he will be talking on the upcoming role of the antibody drug conjugate, especially the role of the tisotumab vedotin. Rajan boss, please.
So thank you so much, Satya, for having me here. My slides should be visible. And I come from the school of thought where you didn't have much in CA cervix after the platins and taxanes were exhausted. So I belong to that era. But of late, there has been some breakthrough here. I won't exactly call it breakthrough, but because antibody drug conjugates are everywhere. So let's discuss them here as well. So my topic is simple. Is there a role of tisotumab vedotin in advanced cervical cancer? I don't think my slides are moving. Okay. So in a recurrent metastatic cervical cancer, after the progression on first-line therapy, the options have been few and far in between. So there was this unmet need. We all know 17% 5-year survival once the disease is distant and metastatic. And single agent chemotherapy, people have tried methotrexate and people have tried capecitabine. So they had anecdotal benefit, if at all any. So the question that actually arises and that we need to address in this session is, can an antibody drug conjugate change the trajectory of recurrent cervical cancer? And should it stay in the relapse setting or move forward? So there are 2 or 3 trials which I would be discussing here, and then the judgment is up to you. So what's exactly an antibody drug conjugate? We know there's an antibody, there's an antigen which is expressed on certain cancer cells, and we link that antibody along with a linker to a cytotoxic payload, which in most of the cases is a chemotherapeutic drug, either tubulostatic or tubicidal. So in this particular drug, the antibody is tissue factor directed human monoclonal antibody. There's a cleavable linker like in all ADCs, and the payload is MMAE. So what exactly is a tissue factor? The tissue factor is body's primary trigger for blood clotting. So what is it doing in cervical cancer? Its normal job is hemostasis. So what changes in cancer is that many tumors, including cervical carcinoma, aberrantly overexpress this tissue factor on the cells far above the normal epithelium levels. So this is why it's a target there. So this drug, it's like I've explained before, there's an antibody and there's a cleavable linker. It attaches to the tissue factor, it internalizes, and then it releases, and it causes what all chemotherapy drugs do, apoptosis. So why exactly is a tissue factor a compelling target in carcinoma cervix? It's aberrantly highly expressed on cervical carcinoma cells across squamous, adenosquamous, and adenocarcinoma histology. The expression is largely independent of the PDL1 status, a molecule, a surface antigen that we've come to know widely courtesy the immune checkpoint inhibitors. And what makes it druggable is that it's abundant on the tumor cells, far lower on the most normal epithelium, and that gives us a basis of a therapeutic window. There's an internalizing receptor, and there is, like we know in rituximab, direct cytotoxicity plus ADCC, ADCP, and like we know in Diraxetin, a bystander effect. And it's histology agnostic. So be it squamous cell carcinoma or adenocarcinoma, all of them express it to some degree or the other. So how this kills the tumor cells, it binds, it internalizes, it releases, and then kills. So this is the INNOVA program at a glance. INNOVA T4 TVT204 was a phase 2 single arm trial. It established the response signal on the base and was the basis of the accelerated approval. 301 was a randomized trial, second line of chemotherapy versus investigators' choice chemotherapy, and this is what gave it a full approval. And then obviously the medical oncologists and drug companies get greedy, so we brought it in combination. So there is data in all possible settings. I would want to talk only about Innova 301 for the lack of time. So about 502 patients were randomized into either this ADC or investigator choice chemo. Like I described, once a patient has progressed on a fluoropyrimidine, taxane, or a platinum, there are very few limitations, few chemotherapeutic agents left: topotecan, vinorelbine, gemcitabine, irinotecan, or pemetrexate. In India, we obviously use methotrexate and capecitabine also. And the primary endpoint was overall survival, secondary endpoint being PFS. So the results were wonderful. The median survival, overall survival shot up by 2 months, and the progression-free survival was up by 2 months. The OS hazard ratio was 0.70. That means a 30% lower risk of death. And the parameters were statistically significant. The PFS the hazard ratio for PFS was even better. That is a 33% lower risk for progression. So the bottom line is this trial established this ADC and it showed an overall survival advantage. And this was the first time that there was an OS advantage for any agent in pre-treated recurrent cervical cancer. And that was concordant with PFS and response benefits as well. We need to check whether the responses were durable or not. So as we can see, there was an advantage of 2 months and 1.3 months. And about 24% patients confirmed the objective response rate in previously treated recurrent and metastatic disease also. So the median duration of response was 8.3 months. I do agree it's not something significant, but it is, if at all, a movement in the right direction. So safety, it's far more safer than any chemotherapy we know of. Let's agree to one fact that patients who are on third line cervical cancer chemotherapy anyways are PS2 and debilitated. So even in those settings, the side effects were far less than what chemotherapy could give. And there was peripheral neuropathy, and because it is a factor against the coagulation cascades, so there was a risk of epistaxis, and it was documented. And moving forward, we need to bring it in combinations, first line. So about 5-year Innova TV205 shows durable activity, but as of now, I will not recommend it in this setting. So where does it fit today? It's investigational in first line. In second and third line, it's established beyond any doubt in my mind. And practical considerations for the clinic are: one has to be aware of the bleeding. The dosing has to be perfect. There is a risk for conjunctivitis, so that has to be set. And to be very honest, there's just a budge of 2 months. So we don't need to give the patients a lot of expectations. If there is free access or it's a part of trial, I think we should go ahead. Otherwise, unless until the patient absolutely wants those 2 months, I don't think I would advocate for this. And coming to the last slide, how strong is the evidence really? Yes, like I discussed, the absolute gain is modest. We cannot generalize it as yet. And there's no predictive biomarker like the PDL and the PDL1s and the TMBs have been set in other immune checkpoint inhibitors and ADCs. There's no predictive biomarker exactly for this. And the open questions before we move forward are: the toxicity is not trivial. Conjunctivitis is a pain, and bleedings are something which everyone fears. Cost and excess, especially in the setting where I work, is a problem. And the sequencing as of today is unsettled till we get the results of 205. And is there a role for this drug? The verdict is yes, it is in second or third line, but in earlier lines, I would still call it investigational. And 5 points to carry home are: tissue factor is rational, druggable. We have it in pre-treated recurrent diseases, this drug, and the adverse effects that we need to take care of are ocular neuropathy and bleeding. The first line data is still not mature, and I would not recommend it. Thank you so much, Satya, for having me here.
Thank you, Dr. Rajan. And you have made a very complicated topic into a very simple one and very well explained the role of ADC. What is the ADCs? Personally, my take on this is when we were residents, we always used to ask, once the immunotherapy failed, what next? So I think we are in the era of ADCs. The era of immunotherapies is was the last decade. This decade was for the ADCs. And I truly believe, yes, there is much to be done here. The magnitude of benefit is not that much, but we have many other antibody drug conjugates in cervical cancers which are coming up. Like in this year's ESMO, we have this Voluntatic Fofedotin, which is a Nectin-4 ADCs, which is there. And this Tisotumab Vedotin, maybe the patient selection based on the expression could be done. And so thank you. And again, I would like to request and remind all our attendees and panelists, if you have any questions to any of our expert speaker, kindly put it in the chat box. We will take it up at the end of the session or during the panel discussion. Thank you. And moving forward, I would like to now invite our next speaker, Dr. Gaurav Kumar, sir. He is an ex-alumnus of B. Barwa Cancer Institute, Guwahati, and he will be talking on the Ruby trial, survival impact of dostarlimab on the first-line endometrial cancer. Dr. Gaurav Kumar, sir, please.
Yeah, Dr. Satya, I think I am the odd man out here. So we have been discussing regarding cervical cancers, and now we are moving to endometrial cancer. So for the paucity of time, I would not take much of time and would start from the trial. So we will be discussing regarding this trial and this drug, that is dostarlimab, and how had this drug impacted the survival in advanced endometrial cancer. Next slide. So this is my disclosure. The slides has been provided by GSK. Next. So coming to the rationale, why should we combine an immune checkpoint inhibitor with chemotherapy in advanced endometrial cancer? Next. So if we go by the treatment paradigm that has changed over time for endometrial cancer, starting from the old backbone of chemotherapy, that is taxane and platinum-based chemotherapy. Then we had certain hormone therapies for ER-positive tumors. Then HER2/neu therapies were there for specifically for HER2/neu positive tumors. Then even checkpoint inhibitor in combination of chemotherapy came mostly for the MSI high tumors or deficient MMR tumors, where they have shown very good results as compared to chemotherapy alone. So there have been lots of trial with these combinations of different immune checkpoint inhibitor, be it dostarlimab, be it pembrolizumab, be it durvalumab. All of them, when combined with chemotherapy, has given us good survival advantage in advanced endometrial cancer, which is beyond what we have achieved with chemotherapy alone. So we know basically this endometrial cancers. um the immune checkpoint inhibitors, they increase mutations in endometrial cancer. The endometrial cancers, they have increased mutations, and that typically promotes anti-tumor immune reaction inside the tumor, which leads to a lot of immune markers, and checkpoint inhibitors comes in handy in this type of tumor. And when we combine it with immune checkpoint inhibitor with chemotherapy, then the cytotoxic chemotherapy, they produces further anti-tumor immunity by inducing the immunogenic cell death, which increases the intratumor T cell infiltration, and that becomes more and more targetable with the help of immune checkpoint inhibitor. Next. So coming to the biomarker testing, yes, it is the standard of care currently that in all advanced endometrial cancers, we do check biomarker at the baseline only, which includes testing for HER2/neu, testing for MSI, testing for ER status testing, and an option of NGS always remains for testing uncommon variants or uncommon targetable mutations. Next. So basically, what's the biomarker testing has given us in endometrial cancer? So we can see that testing may provide us with important information about the patients. So coming to the DMMR or MSI high tumors, when we do a when we test all of our patients of endometrial cancer for this MSI high, we roughly get almost one-fourth of patients do have high MSI in those tumors. So one-fourth of patients do become eligible for immune checkpoint inhibitor. Not only eligible for the immune checkpoint inhibitor, this MSI high tumors behave differently from MSI low tumors. If you see the prognostic importance of MSI high tumors, they have a poor prognosis due to a high recurrence rate, and they also produces higher distance metastasis. So MSI high tumors are a group of are a subgroup of endometrial cancer that have poor prognosis and that also makes them eligible for addition of immune checkpoint inhibitor. We can do MSI testing whether by ISC or by a PCR on NGS. Next. So coming to the trial that has established the role of dostarlimab in endometrial cancer, that is Ruby part one. And if we move on to the trial results, next. So basically, it's a phase three randomized trial where all patients of advanced endometrial cancers were included, be it a deficient MMR tumor, be it a proficient MMR tumor. And if you see the subgroup, one-fourth, almost one-fourth of the patients in this trial were deficient MMR, that is MSI high tumor, and three-fourths of the patients were proficient MMR tumors. They were randomized into 1:1 ratio. To one first arm was the control arm was standard chemotherapy backbone of paclitaxel and carboplatin every 3 weekly for 6 cycles, followed by placebo. And the experimental arm was Jemperli, that is 500 milligram dostarlimab, along with paclitaxel carboplatin for 6 cycles every 3 weekly. And after completing 6 cycles of chemotherapy with dostarlimab, they move on to give dostarlimab maintenance. And schedule was changed to 6 weekly, and dose was increased to 1000 milligram IV. And the duration of total exposure to dostarlimab was kept up to 3 years. The primary endpoints were overall survival, median PFS, and they have also done the subgroup analysis in deficient MMR tumors versus proficient MMR tumors. And additional exploratory endpoints were objective response rate and duration of response. Next. So, what makes this trial, Ruby trial, a bit different from the other keynote trials and durvalumab trials in endometrial cancer? That this Ruby trial has included certain varieties of endometrial cancers based on their histology. These are aggressive histologies were also included in the study, where we can see that almost 10% of patients included in the studies were of carcinosarcomas, and almost 20% patients had serous adenocarcinoma. So these are the histologies which do confer a poor prognosis. And as compared to the pembrolizumab trial, which has not included this adverse aggressive histology of endometrial cancer, Ruby Part 1 trial has included these histologies also in their setting. Next. So as I was discussing the histologies which were included in this trial, we can see mostly the patients were of endometrial adenocarcinoma, 54%. We can see there is almost 10% of patient of carcinosarcoma in this study, and 20% patients of serous adenocarcinoma were also included in the study, along with the other rare histologies like mucinous carcinomas and undifferentiated carcinomas. And in this trial, we can see 18% patients were of FIGO stage 3, 34% patients were FIGO stage 4, and but almost 50% patients of endometrial cancers included in this trial were of recurrent disease. Next. So coming to the results or endpoints of this study, for all the patients who are included in treatment for this in this trial, for all comers, we can see we can see we have achieved a 16.4 months improvement in median overall survival as compared to chemotherapy alone. So the addition of dostarlimab with chemotherapy has given statistically significant 31% reduction in risk of death, and we can see the median OS has jumped to 44.6 months in dostarlimab but chemotherapy arm versus only 28 months in chemotherapy arm. So OS at 2 years, if you see 70% patients were alive with dostarlimab and chemotherapy combination as compared to 54% patient in chemotherapy alone. Next. If you see median PFS for all the patients included in the study, and those with aggressive histologies, in those subset of patients with aggressive histologies, although the OS has been 11.8 months with dostarlimab with chemotherapy combination as compared to 8 months with chemotherapy only. So again, in these rare histologies also or aggressive histologies also, this addition of dostarlimab with chemotherapy or has given us benefit in terms of overall survival. Next. Coming to the additional endpoints that for the studies like the objective response rates, we can see there is a significant jump in terms of objective response rate, which has been achieved with Jemperli and chemotherapy combination as compared to chemotherapy alone. And almost it was 70% objective response rate in the immunotherapy chemotherapy combination versus near about 65% objective response rate with chemotherapy alone. So median duration of response with Jemperli and chemotherapy was 10.6 months as compared to only 6.2 months with chemotherapy alone. So there has been a significant increase in duration of response, significant increase in overall survival with addition of this dostarlimab with chemotherapy as compared to chemotherapy alone. Next. The most important part that this trial has included patients of both deficient MMR and proficient MMR. So coming to the subset of patients, those were deficient MMR or MSI high tumors. In that case, the addition of this Jemperli with chemotherapy, that is dostarlimab with chemotherapy, has given a big magnitude of difference in terms of overall survival and PFS. So you can see the median PFS has not been reached in the dostarlimab chemotherapy arm as compared to 7.7 months with chemotherapy alone arm. So this is the subset of patients where the addition of this drug dostarlimab with chemotherapy has given us a huge benefit both in terms of overall survival and PFS. Next. And this is the OS in deficient MMR patients. Again, the OS has not been reached in this dostarlimab chemotherapy arm as compared to 31 months with chemotherapy alone. I think you can mute Dr. Tarun Durga. I think we have been having some. Yeah, thank you. So median OS and PFS both were significantly high in deficient MMR group of subgroup of tumors when we are adding dostarlimab with chemotherapy as compared to chemotherapy alone. Next. Again, in this subgroup of MSI high tumors, we can see that objective response rate and duration of response rates were significantly higher in dostarlimab chemotherapy arm as compared to chemotherapy alone arm. Next. Now coming to the subset of patient, that is a 3/4 of the patients in the trial included were MMR proficient, that is MSI stable. So in that group of patient, if we can see the median OS, there has been some increase in median OS, but the magnitude of benefit was low in adding dostarlimab with chemotherapy in MMR proficient tumors. Median PFS was 9.9 months with chemotherapy and Jemperli, and it was 7.9 months with chemotherapy alone. So this subset of patient has not given us the same amount of benefit that deficient MMR tumors has given with addition of immune checkpoint inhibitor. Next. So coming to the doses of this drug in combination with carboplatin and paclitaxel, as already mentioned, along with the chemotherapy backbone, it is given as 500 milligram IV infusion every 3 weekly, and after 6 cycles of completing chemotherapy, we start on sort of maintenance with this drug, 1000 milligram per meter square every 6 weekly for a total of 3 years completion. or progressive disease before that. We stop the drug. Next. So coming to the subgroup analysis of this trial, Ruby trial. Next. You can see these plots which are for PFS and OS for Ruby Part 1 trial. According to the molecular subgroup, the curves on the left side is for progression-free survival and overall survival for patients who are deficient MMR. The second one is for polymutation. Third one is for this no specific mutations identified group. And fourth one is for TP53 mutated patient versus non-mutated patient. So for deficient MMR patients, there is a huge gap between the curves of dostarlimab chemotherapy versus chemotherapy alone. Again, in TP53 mutated patient, again this drug addition of this drug to chemotherapy has given us bit advantage as compared to chemotherapy alone. But for patient with no specific molecular mutations, this drug has not given us that same amount of magnitude of benefit as compared to the deficient MMR group or the TP53 mutated group. So these are the two subgroups of advanced endometrial cancers where we expect a huge advantage of addition of dostarlimab with chemotherapy as compared to chemotherapy alone. Next. So what about the therapies after the use of this drug with chemotherapy? So if you can see from this table that even in patients who are deficient MMR, even after using the dostarlimab with chemotherapy upfront, almost 50 to 53% of patients go on to get a second line immune checkpoint inhibitor. And this second line immune checkpoint inhibitor in chemotherapy alone was almost 70%. So this is the subgroup where you can think of rechallenging or changing the immunotherapy or immune checkpoint inhibitors after progression on first line immune checkpoint inhibitor with chemotherapy. But in other proficient tumors, even if patient has not been exposed to first-line immune checkpoint inhibitors, giving it in second line has given us some advantage over the conventional chemotherapy, but the magnitude of benefit is not as huge as in deficient MMR tumors. Next. So the PFS2, as we were discussing, that is in second line therapy for deficient MMR population, you can see the PFS again in deficient MMR tumor has improved. There is a huge benefit as compared to in dostarlimab arm as compared to placebo arm. And I was used in 70% of patients who have received follow-up chemotherapy in placebo control arm. In spite of immunocheckpoint inhibitor used in second line therapy for chemotherapy arm of Ruby trial. In spite of that, also the PFS2 benefit remains along with the uh, patient who has received first line immune checkpoint inhibitor with chemotherapy. Next. And MMR proficient tumor, again, there was a bit benefit with addition of dostarlimab in first line therapy as compared to placebo with chemotherapy, but the magnitude of benefit was not that high. But still, the curves were well separated and it remains separated throughout the longer follow-up duration. So PFS2 advantage was also present in MMR proficient tumor who have received first line dostarlimab with chemotherapy. Next. Coming to the adverse drug reaction, whenever we want to add a drug to a already standard arm, we always look not only on the results, but we should go ahead and see what all toxicity does it producing. Next. So this drug is a pretty well manageable drug in terms of the toxicity profile that I was going through. Temporarily with chemotherapy, they exhibited a manageable safety profile, and but there were almost 19 to 20% permanent discontinuation of this drug due to adverse reaction, and mainly these adverse reactions were infusion-related reactions, rashes in some cases, thrombocytopenia in some cases. And other than that, we are going to see, as expected, increased rate of immune-related or emergent immune-related adverse events with addition of an immune checkpoint inhibitor with chemotherapy, which include, and the toxicity is not much different from the other drugs that we are already using, like pembrolizumab, nivolumab, or durvalumab. And then the immune-related adverse event with this drug, dostarlimab, is again this almost similar. Like hypothyroidism was the most common endocrinopathy which was seen with this drug. Rashes were higher, arthralgias were higher, almost in the ratio of almost in the range of 6%, and transaminitis was also almost 6% with this addition of dostarlimab with chemotherapy. And if you see serious adverse event, it has occurred in almost 39% of patients who has received dostarlimab with chemotherapy. And the most common serious adverse events were definitely sepsis that has occurred in 3.3% of patients, and pulmonary embolism again in 3.3% of patients. And death rates were lower with the use of this drug. Next. So these are the immune-related adverse events with the addition of dostarlimab with chemotherapy, and I'm not going to in detail with, of this immune checkpoint inhibitor associated side effects. Next. So dose reduction is important. Generally, for this trial, the dose modification for this dostarlimab for adverse reaction that require management were different for general guidelines. Next. So it is just almost similar to other immune checkpoint inhibitors. For most of the patients with grade 3 and 4 immune-related toxicities, we do discontinue the drug permanently. But in certain conditions like pneumonitis or like hypophysitis, where we should be very much vigilant about detecting the side effects early, and even in grade 2 reactions, we have to stop the drug, see how the patient is recovering, and be very cautious in re-challenging the drug in these cases, because second episode of this type of adverse events can be fatal in those patients. Next. Again, for other immune checkpoint inhibitors, for like myocarditis, and these are very fatal sort of side effects. And for these type of side effects, we should permanently discontinue the drug, even with a grade 2 type of uh, grade 2 severity of reactions also, or toxicities also. Next. So these are the important safety information. Infusion reactions. We have uh, uh, well documented protocols for decreasing the infusion reactions with the drugs. Yes, this drug should be used very cautiously. Either it should be avoided. Better it should be avoided in patients who have already received allogenic stem cell transplant. Next. Coming to the summary of the talk. Next. So there is a 16-month improvement in median OS for all patients. All patients, mind it, this includes the patient who are DMMR and MMR proficient. So there is a 16 months improvement in median OS when adding this dostarlimab with chemotherapy as compared to chemotherapy alone. This is a robust trial design because it has also included aggressive histologies, and it has a good 3 years plus follow-up for the efficacy endpoints. And the manageable toxicity profile of this drug makes it easy to use in combination with chemotherapy. Next. And I think that's all from my side. Thank you. Over to Dr. Satya.
Thank you, sir. And I think GSK will take note of this. And next time when we meet, we'll be seeing the utility of dostarlimab in cervical cancer also. I think the last year ESMO, we have seen the atomic CC trial data. It was the phase 2 data of the utility of dostarlimab as a consolidation therapy after CTRT in high-risk cervical cancer. So maybe boss next time will not feel the odd one out. Anyways, thank you, sir.
Thank
Uh,
you.
so now I'd like to move on to the last session, the panel discussion, an exciting panel discussion by our moderator, Dr. Sashank Bansal. And we have a very exciting panelist, stalwarts of GCI, SGPGI Lucknow, GCRI Ahmedabad, and NHS England. So Dr. Sashank, I would like to invite you and kindly also invite all your panelists. Thank you.
Thank you, Satya sir, for giving me this opportunity. And I would like to invite also my all of my panelists. Please join and open your mics. So, and I would request the organizer to please share my slides from your side. It is getting difficult to share from my end. So we have got a very august panel here with Dr. Sajjan Rajpurohit sir. He is very senior medical oncologist. Dr. Shalini ma'am, Dr. Deepak sir, Dr. Apurva ma'am, Rajan Yadav sir, Dr. Sonali, Dr. Shushma Agrawal ma'am, Dr. Ashutosh Jaiswal sir, and Dr. Tarun Durga sir. Sir, sir, should we start the discussion?
Yeah,
Yes,
sir.
yes,
Yeah.
please start the speaking.
Sir. Slide number one. Please share the slides. So, as you know, that cervical cancer is the fifth most commonly diagnosed cancer, and almost 6 lakhs of cases was diagnosed in 2024, and out of them, approx 3 lakhs cases of death were reported. And the highest incidence has been seen in the low and middle income countries, and predominantly it has been because of the HPV infection, for which we have vaccination right now, and people living with HIV has 6 times more likely to develop cervical cancer compared to women which are not having HIV. And worldwide countries are accelerating the efforts to eliminate cervical cancer by guided by a global 90-70-90 targets. Next slide. So, among the world, Southeast Asian region ranks second among contributing approx 30% of the global cervical cancer cases and causing 34.212% deaths of all the diagnosed cervical cancers. This is very huge. And in India, if we see, as per the 2022 data, 1,30,000 cases were diagnosed, and out of them, around 80,000 deaths were reported. So, nearly 60 to 70% of the patients they have experienced death uh, after diagnosis. So the data is not so very encouraging. And 60 to 70% of the cases are detected in very advanced stage, but because many VIA positive screen movement, they do not turn up for colposcopy and further confirmation. And there are major factors which are contributing to this is the inadequate screening coverage. So next slide, my question to panelists is like how many individuals walk into your clinics or in your clinical practice asking for a cervical cancer screening or HPV vaccination? Any of the panelists can take the question.
About 2 or 3 every week.
2 or 3 every week. Are they coming?
Yes. Because we have an extensive program here in Gujarat. It's reached
Okay.
the school levels.
Okay.
So yes, 2 to 3 plus. We kind of mandate it for all our staff workers, like the
Okay.
nursing staff and the physicians, to get their kin here. So yes, 2 to 3 weeks.
Okay. So that's
2 to 3.
really encouraging, and I think there is a big divide between rural and urban areas. Maybe urban females they are coming more for
They're
screening, but
all only urban.
all sir,
Yeah, all urban.
all of them. So probably mostly from the urban area, or sir from rural area as well.
Mostly from Ahmedabad district, urban.
So, okay. And what about vaccination status? Are the young girls getting vaccinated?
Yes, so we have a school health program here in Gujarat,
Okay.
wherein we have a tie-up with Gardasil 9.
Okay. Okay.
So we just give one dose,
Okay.
and the booster is optional.
Okay.
So about 2 or 3 per week vaccinations happen here. But because of the benevolence of government scheme, they're
Mm.
covered free of cost.
Okay.
And we have a tie-up with Gardasil 9. So I think that's the reason, nothing else.
I think that's very encouraging for the state of Gujarat. But I'll still say that most of the diseases happening in the rural areas.
Absolutely,
It's
absolutely,
more linked
absolutely.
to the personal hygiene, which has not been taken care of in rural areas compared to
No,
urban areas.
these are more like girls, school going, people living in my society.
Yes.
You spread a
Mm.
word, some nursing
Yes.
staff will get her neighbor and things like that. It
Mm.
is not rampant.
Absolutely, sir. And sir, regarding vaccination, so if after 26 years of age, up to what
No, the
age you are?
no, the thing is, we have a school health program here
Okay.
where the treatment is free up to 11 years of age, 12 years of
Okay.
age.
Okay. Okay, sir.
So I have not come across someone till
Mm.
date who's over and above 26 years of age.
Okay, so frequently in many, in my clinics also, sir, people come and ask for vaccination, but their age is around 30 to 30 years, 33 years.
I don't think we have enough data on that.
Okay, sir. And
Shashank, I'll just mention one thing.
yeah.
So, there have been studies, telling about adjuvant vaccination. So, per
Mm.
se, it's not, I mean, something which is routinely practiced. But yes, there are some patients who come to my colposcopy clinic, who've been referred with some pre-invasive lesions or due to some
Mm.
HPV positive. So,
Mm.
in these cases, yes, I am beyond 26 years old. So, I am practicing adjuvant vaccination, wherein, in order for patients who are more than 26, still I am giving them Gardasil 9.
Those who are appearing with uh,
Other HP positive, So there is some concept like adjuvant vaccination. So
okay.
protect them from other HPVs. But this is not something for prevent. It's not into a routine practice, but particularly because you mentioned more than 26 years, because
Yes.
is licensed till 45. But
Yes.
when females come and ask you, you
Mm.
can tell them that the benefit is not much, but
Mhm.
if they want to take, they can take. And particularly in those people who are some sort of HPV positive being
Mhm.
undergoing treatment, then yes,
Mhm. Mhm.
anti vaccination I am practicing beyond 26.
That's a very valid point, ma'am, you have made. And regarding that Cervarix versus Gardasil, I think the question is out now. Most of us are using Gardasil, or some of are preferring Cervarix as well.
No, no, Gardasil for us.
Gardasil. Okay. Next slide. So moving on to our main questions. So here is a case of a 71-year-old female presented with us bleeding PV, with the complaints of bleeding PV. On examination, there was a big mass in the cervix, and on further investigation, on CCT was done. There was a bulky cervix with bilateral parameter involvement, and the disease was involving the upper vagina as well. Biopsy was done, which was suggestive of large cell non-keratinizing squamous cell carcinoma. Next slide. And a PET scan was done. So in PET scan, there was a metabolic activity lesion measuring around 1.9 centimeter with involvement of the lower uterine segment and upper vagina. The parametrium were free and no enlarged lymph nodes, and this was normal. Next slide. So this is the most common clinical scenario we see in our clinic, that they have been investigated with CT scan. No uh, parametrium on investigation was normal, and size of the lesion was around 1.9 centimeter. So in certain cases, where we need to surgical call, and patient, if he is not affordable because he has done too many of tests previously, so should we essentially do an MRI, or should we discuss with the patient? Dr. Pura, ma'am.
So yes, if I'm not mistaken, I think you said in the initial phase that the parameter looked involved, is it?
So this is a real case actually, ma'am. One CT scan reported that
Hmm.
there is a parameter involvement. In PET CT scan, they say there is nothing involved.
See, there was a discussion regarding this earlier, in one of our webinars also. Actually, what happens is when there are two things, radiological as well as clinical.
Yes.
Definitely, when clinical, if you have the parametrial involvement, then we do not go ahead with the, it's quite obvious. Sometimes
Yes. Yes.
standing or something is given in MRI, but if MRI may mention just a parametrial stranding, but then when you do a clinical examination,
Mm.
you find the parametry involvement. So my practice
Mm.
is like, clinical examination takes supersedes. But
Mm.
the webinar which we had, they were saying, that when there is no obvious this thing, and but the
Mm.
imaging mentions parametrial involvement, then imaging supersedes.
Okay.
Okay. Uh,
Okay. Okay.
Basically, this is with practice. Uh,
Mm.
when clinically you feel the parameter is involvement, you should not go inside and perform a radical hysterectomy, because whatever we do, the major aim is to give them a single modality treatment.
Okay. Okay. So,
Can I add here? Can
yes,
I
madam.
add?
Yes.
So basically, it's the clinical examination. You have to have a nodular feel of a parametrium. That is when the parametrium is actually infiltrated, because parametrium can itself be inflamed because of, because there are changes, there is a disease which is there. So an inflammatory para can be there, which will be seen in an which a image will capture, like a CT scan can capture an inflammation of the parametrium, which is like differential is like PID and all, right?
Yes,
So
yes,
an
yes.
inflammatory, like a nodular para on clinical examination, therefore supersedes any gray zone areas. If an MRI is catching, that's when you will say that the parametrium is infiltrated. So
Mhm.
these are the subtle things which needs to be seen before we can say actually the parametrium is inflamed or
Mhm.
it's involved. That is just like I'll add on to the findings of the discussion.
Uh, very well taken, ma'am. Thank you. And so, considering this is a localized disease, a size of around 2 centimeter. So, Dr. Apurva, ma'am, should we go ahead with the surgery in this elderly lady?
Definitely, we can go in for surgery in a 2A1 disease also, and we can perform surgery definitely. So, what is her age? Age is no not a criteria
71.
of
Age is
status.
not a criteria. She's fit enough. Only
Yeah,
diabetes
fit
is there.
enough, then yeah, definitely we'll go ahead with surgery.
So,
We perform type C1 nerve sparing radical hysterectomy with bilateral PLND. The first practice is always performing a pelvic lymph node dissection, and whenever it looks like you want to, there is some enlarged node or something, we do a frozen, and if it comes out to be positive, and then we definitely abandon the procedure, or else we go ahead with the type C1 nerve sparing radical hysterectomy for this case with PLND.
Shalini ma'am, should we had this patient came to you, should you have offered this patient surgery, or should have taken that patient for CTRT?
She's a 71 years old lady. She has diabetes. Although you have said that her fitness is very good, but we
Mhm.
know that a lesion which is 2 centimeter, which is an early disease, even giving chemoradiotherapy has a similar
Mhm.
outcome uh,
Mhm.
to surgery. So I would definitely discuss this and offer her chemoradiotherapy.
And keep the surgery for the salve as a salvage option if the something happens further.
Yeah, definitely. I mean, that just now we have all discussed the recent updates, and we know that chemoradiotherapy and brachytherapy, there is a lot of innovations which has happened, and the results are very encouraging and good. So,
Mhm.
definitely, surgical salvage will be kept as a side, an option. Yeah.
Okay. So, so, Sajjan sir, I would like to ask one thing, sir. So, when we usually were adding cisplatin with the radiotherapy, those patients you are getting radiotherapy. So, since she is elderly having SNHL, so should we prefer cisplatin or should we shift for carboplatin? Had she been not having SNHL, then adding replacing cisplatin with carboplatin would have any impact on the patient outcome?
Um, so, Dr. Shams, I think, yeah, such patients are really important cases in tumor burden because going for both the approaches might be right. Surgeons might feel that we can make the patient undergo surgery, whereas the chemo radiation can be done also done. Now,
Mm.
it's very important also to understand that how is the fitness of the patient otherwise, and what is her renal function also. That's very important because
Okay, sir.
I think wherever possible, if this pattern is being used along with the your radiation, I think it will be
Mm.
probably at par with the surgery. But if you have to replace for carboplatin, I don't think it will be like as good as surgery. So I think if the patient is not a good candidate for platinum, which is 56 platinum,
Mm.
then we might have to favor more towards surgery.
And what if now we have data for concurrent immuno as well? So and
Yeah.
so if she's fit enough
So
and financially well off for that, then what should be our choice of regimen to go ahead with, sir?
I think into a probably I don't know how much benefit would that cause. I'm not very sure as to
Yes,
whether
yes.
because I think the more data is in stage
Mm.
three.
Yes.
So I won't be really very like really enthusiastic about using uh, uh, kind of immunotherapy at this stage.
Okay, so point well taken, sir. So my question to Dr. Sonali should be,
Yes.
am I audible, ma'am?
Yes, yes.
Yes, sir. So, ma'am, if we are planning this patient for CTRT, so what will be your preference, 3D CRT or IMRT?
I will definitely take this patient for IMRT as we have discussed earlier also that
Yeah.
the bowel toxicity, GI toxicities are less with IMRT technique as compared to 3D CRT techniques. And with the advancement of technology, obviously IMRT I will prefer for this patient as an
And
EBRT option followed by
is,
brachytherapy.
is there any role of hypofractionation in this case or hyperfractionation versus the conventional one?
Yeah, sir, as such, there are trials which is comparing the role of conventional fractionation 5 weeks regimen with 3 weeks, but we don't have that much of data for hypofractionation or hyperfractionation. So, as per now, conventional fractionation with a dose of 45 to 50.4 grain, 25 or 28 fractionation, I will prefer that for the patient.
Uh, Sushma, ma'am, is there any, uh, what is your experience with uh, bone marrow sparing IMRT versus conventional IMRT in the CA cervix cases? Because we see a lot of neutropenia patient when they are getting concurrent chemotherapy along with the pelvic radiotherapy. So,
We don't have experience, but there is data that bone marrow sparing radiotherapy is definitely better.
mm.
And so those people who can practice, they should practice it.
So what is the means if we are not practicing, then is there any technical reason behind that we are not able to follow that or something else?
No, it is not a technical reason. Basically, it is more exhaustive, and you have to delineate the entire marrow, and then you have to do IMRT, which may not be possible in a daily setup, and maybe it is more in a research setup. So that is what I would say.
Okay.
So
Uh,
actually, if you look at the bone sparing versus non-bone sparing,
yes, sir.
actually acute hematological toxicity and
Mm-hmm.
not linked. Another
Yes, sir.
thing to bear in mind is that when you're going for the bone marrow sparing,
Mm,
you actually slightly increase the risk of sparing the nodal volumes. So actually, your delivery mechanisms, that is the gating techniques, have to be perfect. You
yes,
have to
yes.
be absolutely certain that
Mm,
your movement errors are practically nil. If you are not able to deliver that kind of radiotherapy,
mm,
just planning it out is
mm,
actually not ideal. So the quality control with regards to bone marrow sparing IMRT has to be really very meticulous. And if you look at the volumes, if you look in public sector and volumes, it's
mm,
actually a very difficult thing to deliver. And the meaningful gains from that are low. So
mm,
unless and until you are treating, if you're going normally with the cervical radiotherapy, you're not really going high up on the chains with regard to the nodes. Unless and until you're planning to go higher up, including the high chain nodes, I
mm.
really don't think it's going to add much value apart from acute toxicity.
Absolutely, sir. A point very well taken, sir. And coming next slide, coming on to our next case. It is a 60-year-old female presented with lower backache and white discharge per vagina. Examination under anesthesia was done in which there was a cervical mass present and bilateral parametrium was involved. On examination, rectal mucosa was free. Biopsy was commercial carcinoma. Her creatinine was 2.5. And on MRI, there was a 3.8 by 4.3 centimeter mass which was involving the cervix. And on MRI, it was seen that the anterior wall of the rectum was involved. But on clinical examination, rectal mucosa was free. So there was bilateral pelvic lymph nodes were enlarged and bilateral HU was present. So in this case, sir, how should we proceed? What should be done first, and what should be our first step? So apart from having a digestending and neurological examination, bringing the creatinine down, considering all these has been decreased, then how should we proceed further, sir? Dr. Rajan, sir, would you take this, sir? Hello, Rajan, sir?
Oh,
Sir?
oh, oh.
Hello?
Okay, no, I'm not present here this side. I'll take this question.
Yes, sir,
So
sir.
Dr. Shang, I think with this kind of case, very important first to at least have that good creatinine levels and do stenting or key placement. And once that is done, probably it might be prudent to start on chemo radiation along with the addition of immunotherapy. That's what I feel could be an appropriate step for this patient.
Okay, and sir, is there any role of neoadjuvant chemotherapy in certain cases?
Yeah, sure, sure. So sometimes our radiation colleagues might not be very comfortable to start because of the extent of disease and especially the stenting also being done. So we can always start with neoadjuvant, and then once the patient is better, then we can confirm chemo radiation.
Okay.
So
So,
there,
Dr. Bansal,
Sir.
I'm audible now.
Yes, sir.
I,
Yes, sir,
I
you are
would
audible, sir.
I would like to gravitate towards neoadjuvant chemotherapy in this particular case.
so there are a few things I want to know from A, what was the reason for increased creatinine?
Hmm.
Are the kidneys that are affected, or is there an obstructive component
So
to it? That's one.
on MRI, it was obstruction, sir, causing bilateral hydrohydronephrosis, which was, I think, that's why we should do a
You put a
stenting.
stent. Yeah.
Yes, sir.
You put a stent. So
Yes.
I think NACT would make everyone comfortable.
Okay, sir. Okay, okay. So, to my radiation colleagues, Shushma ma'am, Shalini ma'am, Sonali ma'am. So, is there any reservation for you to send patient for neoadjuvant chemotherapy or directly take patient for CTRT? And if not, then what are the points you consider? Is it that the patient receiving neoadjuvant chemotherapy had delayed with the severe hematological toxicities during CTRT or anything else?
So, in my experience, because we are working in resource constrained settings where don't have an immediate radiation, uh,
Cervix is a
like
disease of resource constraint, ma'am.
no, no, in
अच्छा
our setting where we have a long waiting list for radiotherapy,
जी
so therefore we are not able to start radiotherapy immediately in
हम्म
our government setup. That's what I mean to
yes
say.
yes 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 yes.
So therefore we have been giving neoadjuvant. We had to give like because the patient is waiting, it's not good. We give them and there will be downsizing.
Mm,
So recently, I analyzed my 10-year data of 150 patients,
yes sir.
and we have submitted it also for publication. We
Mm,
presented it in Eastro, and the data is so good. Like you have the 5-year survival of about 90%, and the DFS is about 85%. And so, therefore, neoadjuvant is really very good for the advanced cases, that is 2Bs and 3s. And it has not been tested in this setup only. People
mm,
have given concurrent immuno, but they have never given neoadjuvant followed by concurrent. So, it
okay.
is a very good modality. That is what I want to say.
So do you change your treatment volumes or you keep it same as to the previous to what in what images have shown in the neoadjuvant before the neoadjuvant therapy, or you modulate your clinically targeted volume
So
after the patient receives
we
it?
keep it post neoadjuvant, whatever volume we get it after downsaging.
So in this case, like there was a anterior rectum wall was involved in the MRI, not on the clinical. So in that case, you would decrease your, you will try to reduce the volume to the exact
Yes,
extent of the
yes,
disease post
yes,
image.
yes, yes, yes. There isn't.
Okay.
So we in our analysis we didn't have 4A cases.
Mm-hmm.
So therefore,
4B.
I can't say that. I cannot say with conviction about those rectal involvement. We had basically all the cases which were 2Bs and 3As and Bs.
Okay.
So therefore, with conviction, I won't talk about rectal involvement.
Can
Okay.
I can I add here?
Sure, 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 ma'am.
First of all, if an MRI is showing an anterior wall of rectum
Yeah, not
involvement, we
clinical
have to.
involvement.
I'm not clinical. I think
Yes,
one
yes.
should have a sigmoidoscopy to prove that the infiltration is there or not. Because sometimes it could be a little higher up, and your fingers are not able to reach to that level.
Considering it is
So
not there, no?
definitely, it's not there. The other thing is like her CRAT is 2.5. I mean, giving an anterior chemotherapy, we need to see what is her the glomerular filtration rate and
Yes,
all,
yes.
whether her kidneys are good enough to tolerate the neoadjuvant chemotherapy, and then obviously what type of neoadjuvant chemotherapy,
Mm.
even if we are considering that. So, I mean, in such cases, I would definitely do all these things. And if she is a candidate where her GFR is good enough, only then I will consider some sort of even chemotherapy adding. Otherwise, it's very difficult to give platinum-based chemotherapy along with radiotherapy, even that, where we need to sometimes change the type of chemotherapy. So all these things needs to be seen before we can offer her what we are trying the best type of standard modality.
Yeah. So I think even if we are giving neoadjuvant or not, or directly proceeding for CTRT, this kidney thing has to be addressed, because the similar thing we'll be experiencing when we'll be giving concurrent chemotherapy. So that will hamper the concurrent as well, not only the neoadjuvant thing. So point well taken, ma'am. Coming on to our next case. Next slide. So she's a 45-year-old female presented to us with the complaint of backache and bleeding PV. On examination, there was a growth in the cervix and biopsy was SCC. And further test was also done, which PDL1 was done. CPS was 15. And PET scan showed a FTGF solitary lesion in the liver, cervical mass with infiltration to the parametrium and uterus. Bladder rectum not involved, but there were multiple lytic bone lesions in the humeral lead and the left pubic rami. Next slide. So, my question to Dr. Tarun sir, what other relevant biomarkers we can check upfront in a de novo metastatic case apart from this? Or then how should we proceed for the treatment in this case?
Can you go back on the last slide because I didn't hear what markers you did? I'm
Yeah,
sorry.
please. I
Yeah, just
depended only PDL1 was done, sir.
okay. So now next, yeah. So she's got metastatic disease. I think clinically speaking, right now I'm only doing PDL. We are not doing anything like comprehensive gene panels, although we do have other genes that are being looked at. But the realistic thing is the PDL one right now.
Absolutely, because other approvals are in the later line zone also,
Yes.
and most of the approvals are tumor agnostic approvals.
Yes.
So it is relevant to do PDL1 only. Other markers are not necessary in this. And how should we proceed, and what should be choice of therapy in this? Considering the PDL1 CPS is 15, then what should be our ideal treatment in this, sir?
My personal experience has been with pembrolizumab.
Okay.
So I have used pembrolizumab PDL positive patients, and it does well.
Okay, sir. Okay, sir. And Ashutosh sir, is there any Ashutosh sir? You are with us?
Yes.
Sir, is there any you have any experience of adding serplulimab in immunotherapy along with chemotherapy and or pembrolizumab?
In my experience, I have used pembrolizumab along with chemotherapy in such patients.
Mhm.
Although sertullimab, I have not in the cervix cancer. I have no experience of adding sertullimab.
Okay. And what about bevacizumab, addition of bevacizumab? Do you consider adding bevacizumab for any specific indications, or do you reserve that for the later lines of therapy, or not at all recommend?
So, I mean, we can add bevacizumab, considering the disease status and bulk of disease. If there is no prior, means there is low risk of any fistula formation and all those things, no hypertension is there, then we can add bevacizumab.
What about suppose if the patient has an anterior bladder involvement or posterior rectal mucosal
Yeah,
involvement? So in that case, also would adding bevacizumab would help or should be contraindicated?
but if there's risk of fistula formation, then I would like to hold on for base illness.
Okay, and you go ahead with the chemotherapy,
Yeah, chemo and immunotherapy.
chemo and immunotherapy, sir.
So actually, if you go back into time, so with regards to radiotherapy as well, when we suspected that there was risk of fistula formation,
Mm,
that would indirectly become a contraindication. But actually,
mm,
we do know that if there is disease and if we treat, there is
mm,
always going to be risk of fistula formation. So we have fistula formation either due to disease treatments, or fistula formation can happen because of the disease per se.
mm, mm.
So my what would be my preference? Would I take the risk? And again, these are not black and white decisions.
Yes.
Would I take the risk with regards to fistula being formed as a sequelae to treatment, or would I want the fistula be formed by the disease? If I have a choice to do, I would rather want it as a sequelae to treatment rather than the disease per se. And
Mm-hmm.
that is particularly true when it comes to radiotherapy. Now, when it comes to seismic therapies, bevacizumab, the additional benefit of bevacizumab to conventional chemotherapy is small. So I would avoid bevacizumab for that reason.
Okay, sir. Okay, sir. Thank you, everyone. I think that's all from my side, Satya, sir. Thank you.
Thank you.
Thank you. Thank you, all the panelists. Thank you. Thank you.
Thank you.
Uh,
Thank you all.
thank you to all our panelists and moderator Dr. Shashank Bansal for this incredibly rich masterclass level discussion. I think we have two questions. I would request our panelists to just remain with me for a moment more. And I think we had one question from Dr. Jayaraman Surendran that without brachytherapy following CRT, the local control and regional control cannot be sustained. DFS and PFD will be compromised, even though OS can be comparable. So I think I didn't get the question here exactly. So I'll move on to the next question by Dr. Geeta Singh. With the adoption of de-escalated surgery, has the requirement for adjuvant radiotherapy or chemoradiotherapy changed compared with radical hysterectomy? So maybe Shanli ma'am or Dr. Ashutosh or Dr. Tarun, maybe you can take this question, please.
So, I mean, just like Apurva said, that these de-escalated trials are done in for very early tumors. So these early tumors, obviously, they would then come in the low risk category of if the pathology comes out based on the Peters criteria and the Sedless criteria. So if they are very low risk where we do not have stromal invasion and obviously the tumor size is already less than 2 centimeter, they would not require any form of any adjuvant radiotherapy, and an observation is what would be done. Only if pathological criteria where there is LVCI and if there is a stromal invasion beyond 2/3, where you would require some sort of adjuvant therapy, maybe either brachytherapy, or if sometimes parametrium can come as positive, even microscopic parametrium, there you may need to add external radiotherapy. So based on that, when decisions will happen.
Sure. Thank you, ma'am. Any
So,
other comments?
Satya, question number one. So, if you actually look at cervical cancer is very interesting. If you look at from early stage to later stages, the component of your brachytherapy is more in early stage. The component of external beam is lower in early stage. As the stage increases, the proportion of the total radiotherapy that you're giving, the external beam increases and brachytherapy decreases. What
Sir, you are not audible. Tarun sir, you are not audible. I think maybe there is some issues with the connection with Dr. Tarun. So I think it's already way over time now. So we would like to wrap up here. And again, a massive thank you from my side to all our phenomenal faculty for sharing their expertise, and to all our attendees. There were over close to 80 or 90 have seen during the presentation. So thank you all for your patience listening. And we hope that we have tried to bridge or translate this historic clinical trials into a routine daily practice. So thank you IAIO for this expert insights, for giving me the opportunity to direct this program, and have a wonderful evening, everyone, and a good night from my side. Thank you.
Thank you, Satya. Thank you.
Thank you, ma'am.
As we draw this evening to a close, I would like to express my sincere gratitude to our esteemed Program Director, Dr. Satya Sadan Sarangi, to all our incredible faculty members, and most importantly, to all of you in the audience for your time and dedication to advancing patient care. Your valuable insights and active participation have greatly contributed to the success of today's event. On behalf of the International Association for Integrated Oncology, thank you for joining us. We look forward to welcoming you again at our upcoming IIO academic programs. Have a wonderful evening. Thank you. Good night.